I'd like to remind you all that in your packs there is an evaluation form. Please, could you fill it out as you go along, because that will help you keep your impressions accurate. So, day 2, I hope you all enjoyed day 1 and are eager to go for our VA day. So that's the theme of today, VA. And our first speaker is Dr. Nada, who will be talking to us about indications and outcomes. Welcome back, Dr. Nada.
Thank you. Okay. I will start with a few cases, and I need to hear an answer from you just to a little bit have more adrenaline in your body. So 2.5 years old girl, 10 kilos, presented with supracardiac total anomalies, pulmonary venous return with large PDA. It's a bit late for this age. It was missed after birth. So she's 2.5. It's okay, no? She's 2.5 years by now. On her echo, she had right-sided dilatation with main pulmonary artery dilated and squashed LV. When she presented, she was deeply cyanosed and in respiratory distress, tachypnic at baseline with hypoactivity from the history. The surgeon decided to take her for surgery. Is there any potential risk? Is she a low-risk patient or high-risk patient? Knowing the physiology of the total anomaly pulmonary venous return and the usual track of those patients, immediate repair after birth, as long as they are obstructed. If not obstructed, they can wait a little bit, but 2.5 years old is too late for her, and with her lung condition or respiratory condition and the echo findings, you expected that the left ventricle is squashed and the right ventricle is hypertensive. So those patients, if they go into surgery, there is potential high risk to be having a stormy course after the OR. So moving on, I was consulted for a potential VA ECMO. So why veno-arterial ECMO? To bypass the sick heart, to bypass the sick lungs. So we need to know the indications for the VA ECMO today. So from this patient, she underwent the surgery. They were not wean her from the bypass, and she was having suprasystemic hypertension, pulmonary hypertension. And she was on 100 per kilo ECMO flows, and she was on ECMO for about a few days as a bridge. Bridge for what? So when the surgeon put her on ECMO, the decision was just to let her die in the ICU instead of OR table, to get her out of the OR, just to switch off the cardiopulmonary bypass. There has to be a bridge. Anyone can tell me bridge for what on this scenario? Recovery. Recovery from what? The cardiac issues. At the same time, since there is a suprasystemic pulmonary hypertension, she needs to be treated for that. So with the treatment in 3 days, if you see the red line, her pulmonary pressure became half systemic and she was weaned from the ECMO successfully. The second case is 10 days old, 4 kilos with TGA, transposition of the great arteries, and intact ventricular septum. The patient underwent emergency switch. He arrived to our hospital as life-saving. In 2 days, the plan was to take him on first day, a working day, to the OR, but the child did not give us time. On a Friday with the prayer time, the baby was desatting. You call people, there's like emergency situation, and the intensivist is trying to improve the saturation, but that saturation was not picked up with difference pre-ductal and post-ductal in a neonate with TGA, most likely, again, TGA with pulmonary hypertension, and the patient responded to nitric oxide, but the saturation was from 40s is around 60s. So They had to take him for emergency OR without much of preparation for that pulmonary hypertension as an impression. So with the failure of coming off cardiopulmonary bypass, again, systemic pulmonary hypertension, they could not wean off the patient from the bypass despite the nitric oxide, so he was put on ECMO. And if you see the lines on the top, the two red lines, this is systemic and pulmonary blood pressure. So as the days passed, again, the patient was treated for pulmonary hypertension, time was given for the heart to recover, and the end-tidal CO2 with weaning the ECMO was showing was showing incremental improvement in the end-tidal CO2, so the cardiac output was improving as ECMOs was weaned off, and that was another survival without complications for this patient. The third case is 3 months old with dilated cardiomyopathy and related to MAPCAS, and patient, there was a spelling error. And the patient post-repair, in the OR, he suffered from refractory circulatory failure. We were called to the OR, patient on 3 inotropes, epinephrine 0.2, norepinephrine 0.2, vasopressin 0.04, very badly cold baby, and the plan was to put him back on cardiopulmonary bypass, but then what? Let him recover for a few hours. Is it enough for this heart? Unlikely. So the exit plan is another VA ECMO. So the patient was supported until he had better heart function. Day by day echo was the answer. So to sum up, the indications of and patient selection for VA ECMO are variable. We'll go first on general principle, then indications and patient selection and contraindications, very briefly. My introduction is about successful ECMOs started from there, from children with congenital heart disease who underwent cardiac surgery, and based on also registry, the cases were increasing year after year, and it's having variable outcome, but the majority is 40 to 50%, depend on the congenital anomalies. However, ECPR is also increasing in pediatrics. That's the report from April 2021. And it's almost comparable to the last report that they released this year. Again, the neonatal cardiac ECMO, if you see it over there, the survival is 40. The survival is about 43%. In ECPR is a bit lower. In pediatric, 53%, with ECPR 42%. Variable center to center as well. So the average survival is 40% at the end. So how do I choose my case? I'm looking for comparable survival to international at least. If not better, you need to have a good scoring system and you need to choose the case. The most important vital principle is to have reversible cases. So I'm not going to bring patients with poor prognosis, otherwise the surgeon say, just to salvage this baby, I will do the surgery, and then you put him on ECMO for 1 week, 2 weeks, 1 month. Doesn't make sense, right? So it has to be reversible from the get-go. Otherwise, there has to be an agreement if it's a bridge for something other than recovery. It has to be a bridge for decision at least. Decision, time decision, and wise decision. You can't just keep going with high resource system, unknown time. So if it is not known, and I don't know this congenital anomaly, at least suspected reversible. For example, babies, they will come with myocarditis. Do you know if it is genetic or viral or idiopathic? He's just a few days old and they're negative family history or poor historian. So time will tell. At least you suspect it's viral from the history and so on, and then you evaluate. The risk of putting the ECMO has to be exceeding the risk. It's not without risk. So putting some inotropes has its own risk, but that the ECMO is higher risk. You need to explain all of that to the family and have an agreement with the surgeon or whoever primary team to come up with that decision. So as Dr. Al-Hanouf mentioned, my aim for ECMO, when you put ECMO, you know your exit plan, or at least you had a plan before you stuck with it. So it is a bridge for recovery. If the child did not recover, then maybe a bridge for transplant. Maybe it's a bridge for ECLS first. He needs ventricular assisted device, and from there he may go to a transplant. Or a bridge for decision. Well, we gave this child a chance, and in 5 days, the survival and the mortality, the mortality is high, and there was an agreement just to wean off ECMO, take it off. So you need to be careful in commencing ECMO in unlikely reversible otherwise, or if you don't have heart transplantation, or the patient is high risk for complications, especially when it comes to CNS insult because of the poor neurological outcome. So be frank in the discussion. The aim to go for the proper choice of your patient always gonna be, I want to recover this, I will wait to recover this heart from whatever illness or disease. At the same time, you rest the heart by unloading the heart on ECMO, so you bypass the heart totally. And later on with weaning, you let that heart start working, oxygenate the patient. I'm not gonna keep the patient on 100% FiO2, high ventilatory support and respiratory. Same in cardiac. I'm not gonna stress this heart with high inotropes. The moment the patient on VA ECMO, you wean off all inotropes and you wait for recovery to minimize the organ dysfunction and the sequel on the heart and decrease the oxygen demands. And then treat the possible cause. As we saw, pulmonary hypertension is the reason, okay, treat it. It's like bronchial asthma, and I will wait on ECMO. Wait for what? Well, you need that lung to recover soon. If it's infection with antibiotics, if it's asthma with the treatment, it's the same for the heart. I need to treat that disease. If it is post-congenital heart disease, remember, surgeon underwent, the baby underwent a procedure. The surgeon needs to assess his performance or assess the child performance after the surgery. Maybe extra step is needed. So you don't wait for on ECMO unnecessarily without extra step. So generally it's indicated whenever the heart is unable to maintain the perfusion and metabolic demands, and it can be used in respiratory cases in neonates who they don't have enough venous access, so they will have veno-arterial access, but my focus was more of congenital heart on this context. Okay, let's take the few scenarios where you're going to expose to a decision to go for VA ECMO. So from the first one, low cardiac output manifestation, and this is generally for any patient who has shock or cardiogenic shock or post-cardiopulmonary bypass. So what's low cardiac output state and poor perfusion? I guess all of us as a clinician, we know what does it mean. So I just stated all of the findings that you need to collect and say, clinical and laboratory, this patient is having low cardiac output state. Sometimes we manage and we do perfect work at bedside, but we forgot to label. So the patient is having refractory circulatory, just to trigger yourself that there is exit. If it is refractory, means I need to consult and do extra step by having advanced support like ECMO. So in any potentially reversible heart, you need to have, you may have a trigger by patient post-cardiectomy or post-cardiac surgery. They have failure to wean cardiopulmonary bypass. That's an ECMO trigger to consult me and to say, yes, this is a proper indication and I'll go for it. And of course, rule out residual lesion. The second, progressive post-cardiac surgery, low cardiac output, or even post-cardiac cath, maybe had valvoplasty and came from the cath cold, very badly perfused, on inotropes, etc., etc. You need to sit with the interventionist and check on the anatomy and his intervention. Was it adequate? Anything can be done extra. Is he a patient with reversible condition that you could bridge for ECMO? It's not every case I'll put him on ECMO and then figure it out, because some of the ECMOs are not weanable if they're not properly chosen. Escalating vasoactive medication should trigger to your assistant a call to you even at midnight. We are on such doses of inotropes. It is on agreement in on the department. We put as 0.2, some center 0.1. You need to consult for it. Epinephrine of 0.1 mic per kilo per minute in pediatrics. Heart failure, different medical conditions. As I said, some genetic or idiopathic are not fit, but we won't know initially. And at any low cardiac output state, maybe related to sepsis or other reasons with hyperlactemia, despite medical support, last is a bridge for heart transplantation. So here is a report about the ECMO for intraoperative cardiac cases. They have supported multiple congenital heart disease, yet some congenital heart disease, we know that the mortality is exceeding others, but at most of the time, they had 50% mortality and good outcome, a fairly good outcome, with few complications depending on the expertise. Continuing with other indications for VA ECMO, major pulmonary embolism. We had a kid with tumor or bedridden for a long time, and he has high risk of thromboembolism, and he had signs of DVT. Well, if this patient had sudden cardiac arrest, you would know that this is a potential. It's not common in pediatrics as in adults, but few cases need to be identified as high risk. So collect that risk to come up with it. As a bridge for pulmonary embolism management, you need to have rescue VA ECMO on those patients. Refractory arrhythmias. So arrhythmias, we know amiodarone most of the time would work. Other medication may work, but few cases they fail to have those kind of medication effectively work on it. I do remember at 5 a.m. the baby was admitted with a bronchiolitis, and he started to have SVT overnight. Well, we did amiodarone overnight, and by morning he started to have every single type of chaotic arrhythmias, from VTAC to VTAC to within 30 minutes he was on VA ECMO. Some centers, they don't have this fancy, let me say, rescue VA ECMO, but in cardiac ICUs, it's available at most of the time because you have all of the logistic and availability of equipment handy. So medical ICUs need to be prepared with the same equipment, because bronchiolitis with the season coming need to be highlighted. Some viruses have higher risk of myocarditis, cardiomegaly, hepatomegaly, tachycardia should trigger. Is there any arrhythmias? Is there any myocarditis? And you pick up the chart. So this is how I teach the team. Triggers. Something triggered me. I'm an ECMO advocate, and you are today the most knowledgeable in the hospital about ECMO. You had a course, you had the knowledge, and now you need to apply it and teach it, right? So we go for it this way, by identifying cases and label them. Refractory pulmonary hypertension, as we saw in our example, unfortunately the pulmonary hypertension is one of the highest mortality, whether medically treated or even with on ECMO. The response is variable. In this review of cases, there was 634 ECMOs have been done. 40% were cardiac related, with 80% required VA ECMO. The mortality with pulmonary hypertension was 51%, a bit higher than other patients who did not have pulmonary hypertension. And the risk, or in the univariate analysis of those patients, the higher risk was among patients less than 6 months or higher than 5 years, pre-ECMO cardiac arrest, and pre-ECMO blood gases, that is, with severe respiratory acidosis or hypoxemia. Prolonged ECMO support is higher mortality. So that's why on 7 days you need to sit as a team and discuss how long we are supporting, if it is 10 days, if it is 14, what's our exit strategy. We just don't keep going, especially in VA. I guess this is, okay, the last point here is ECPR. So VA ECMO has been used as for patients who had high quality CPR if it is commenced within 30 minutes in some institution or within 1 hour, as long as it's high quality CPR and you're sure about it, and it's called ECPR. Some pathways has been published in some centers or being followed, and it was very helpful to time the team, and it's part of the Code Blue team. Okay, medical conditions. I don't know if all centers in every place would do that for medical cases. Some surgeons will reject and will say, I do only surgical cases, cardiac, I don't do medical. But here are some indication, as I mentioned earlier, for medical and septic shock, severe ARDS when the right-sided heart suffered and you have pulmonary hypertension, and neonatal condition like PPHN and congenital diaphragmatic hernia, especially if you don't have pure VV ECMO for those patients. Just to remember, with the COVID-19 MIS-C cases, few cases reported, and like this patient who was 5 years old and required ECMO waiting for recovery. Am I going backward? I had mentioned all of my triggers during mentioning the indication, so I'll skip that. The ECMO contraindication. I guess if you know the indication, you know the contraindication. But for simplicity, I found this in one of the paper, and it was interesting to follow. And we took it into our selection criteria in the hospital, which is having no chance situation. Just to make it simple language for people, that it's simply, it may delay the death and the recovery is guarded. Second, no purpose situation. What is the goal? There's no real goal, because those patients would suffer from decent degree of physical or mental impairment, or no ability to put on ECMO. So if you have like very bad congenital anomalies with abnormal vascular access and you cannot do it peripherally, as long as VA ECMO centrally is doable, it is almost doable for any patient. But talking about peripheral patient, some surgeons would just reject to open the sternum for a bronchiolitis baby. So either I do it peripherally or I'm not going to do it. So sometimes it is the logistic or personal or cannulating expertise might be missing. So generally, any patient who have lethal congenital anomalies or severe impairment and CNS insult are contraindicated. Extreme low gestational age is being also a cut point in some centers, and most of the contraindications nowadays are relative. For surgeons, every case is doable, right? From cardiac perspective, it's important to highlight the aortic regurgitation, especially if it is severe. Why? If you put a baby on VA ECMO and you have aortic regurgitation, that is severe. All the blood is coming back to the LV, distending the LV, making the coronaries suffer. That heart won't recover easily. So in adult, there is an exit. You just do valve replacement. Are there any valves for kids? And for what age? To my knowledge, it's limited by age to do any valve replacement. So especially post-aortic valvoplasty by CAP, we need to assess the degree of regurgitation because of the low cardiac output, because of severe aortic valve regurgitation, putting this kid on ECMO may not have an exit strategy. But if the agreement, let's try for 3 days and there is overestimation, underestimation by echo and so on, okay, we bridge for decision. So let's make it clear. Recovery, otherwise we need to discuss. Also, pulmonary hypertension and a chronic lung disease. Oh, you said in your criteria pulmonary hypertension. My kid is having pulmonary hypertension. You review the chart of that patient. He suffers from recurrent chest infections and he is labeled as chronic lung disease, or he has multiple issues. Then you just skip. Higher mortality, poor outcome. And this is shown in also, in one of the papers that patients who have some viruses have relative contraindication like adenoviruses, some pertussis viruses, and all of the cases I have mentioned has been reported with guarded outcome. So the last relative contraindication, as I mentioned, having vascular anomaly or previously ligated carotid. So the baby is off ECMO, you cannot go for the other side and ligate. Thanks so much. Questions?
Thank you, Dr. Nada, for getting us all going this morning. There's no balloons or videos, but that was very stimulating. So our next speaker is Chris Harvey. Welcome back, Chris. He's going to talk to us about VA cannulations.
I'll go for a bit of a wander then. And don't worry, I have washed my shirt. Cuffs are a bit wet, but apart from that, it's done all right. So I'm going to talk about VA cannulations, as Mark has already alluded to. Now, you can listen to me for the next 5 and 6 hours, and you'll not be any the wiser about cannulation. You can stick needles and dummies, but if you really want to go, you can go and do fancy courses on animal models. So this is one that they run in Paris, where they do sheep. You can go out to Australia and do greyhounds, and they're very fun, quite expensive, and you get to do peripheral cannulations and then track the chest. And you can see the sternum on a sheep isn't easy to sort through. You go up the hill and down the hill, but they are good for learning. So when it comes to cannulation, just like with VV, you've got a few decisions to make depending on the age and weight of your patient. How you would tackle a neonate is not how you would tackle a teenager. You can do an open procedure where you can see the vessels, or you can just do a closed cannulation, usually with ultrasound guided. And then you've got the choice of going peripherally or transthoracically. So a lot of the kids you'll come across needing VA support are post-bypass. You've already exposed some fairly hefty vessels, and often you'll already have cannulas in them. So there is advantages to doing a central cannulation. So you require minimal additional dissection, you get very good drainage and very good return. You can get enormous cannulas in if you so desire. You get improved cerebral perfusion. So you're putting your blood back into the aortic root, goes up the carotids, you get nice oxygen-rich blood providing blood to the brain. You go down to the groins, you don't know really what you're getting up there. You've got increased venting options. You can put pipes in the left atrium. I'll come on to that a bit later. And it avoids something called, it was referred to yesterday as the north-south syndrome or Harlequin syndrome, where the top half of the body gets blue blood, bottom half gets the red blood from the femorals. And by, as I say, by injecting the blood back in the aortic root, you avoid that. There are some downsides. Your cannulas are more likely to dislodge. You can't tie them in really securely like you can with a peripheral cannulation. You get increased risk of bleeding. You've got the surgical site bleeding, you've got bleeding from the sternal edge, There's a higher incidence of needing renal replacement therapy on ECMO with a central chest cannulation. And CVH is often used as a surrogate marker for bad prognosis. Mobile ECMO is difficult, or fun at least. We have moved a lot of patients, well, not a lot, probably about 10 patients with open chests. And it does mean that you've got to have a slightly more specialised team. And there's always concerns about chest function. You can't do physio, you can't prone, you can't do all these things as well as you might with a closed chest. You can do central cannulation and close the chest. Various options there. You can bring the cannulas out through the bottom of the chest, you can take them out through the top, or you can just tunnel them through the chest wall. All a bit fiddly and faffy, but if you're expecting a longer run, it might be worth considering that from the outset. Peripheral cannulation is getting more and more used. Even if you have a stenotomy, you can get the chest closed, you can get the cannulas in peripherally, they're more secure, you get reduced risk of infection, you've moved away from your primary surgical site, reduced bleeding, there's reduced need for CVH, much better transfusion profile, you don't need all the products you would, and it avoids restenotomy. Even if you tunnel the lines, you can't just pull them out, you've got to go back in, open up the chest, go to theatre, take them out, repair the holes, whereas peripheral, you still have to repair the holes, but it's easier. If you're doing peripheral, you can do full percutaneous, as I said, you can open and just make a hole in the vessel, put your cannula in, or the way I prefer to do it is with a sort of hybrid approach. So I open, see the vessels, put my needle in under direct vision, and then put the guide wire up, put the cannula in, and it means you don't have to do anything with purse strings or anything fancy like that. Often you get quite a nice seal just by putting the cannula in that way. And it also allows you to tunnel the cannulas a bit. So you might access the vessel here, but the cannula comes in from below, goes through the skin into the vessel. It gives you a nice stable approach. You can then close the main incision, get better hemostasis. And all this is fine, but actually evidence says it doesn't matter what you do. Ultimately, if you're talking in terms of survival, it doesn't matter whether you go central, peripheral, or percutaneous or open. There's differences, but ultimately the survival remains the same. If you're going in the femoral vessels, one thing you have to remember is the femoral artery is an end artery, so you've got to do something about it. Now there's various things you can do. You can put a small cannula in. Most patients who are on VA ECMO do not need absolutely every mil of flow you can get. They might need 2 litres support, 3 litres of support. And you might get that through a 17 French cannula. You don't need to put a 21 French in, which is completely occlusive. Okay? You can do a Y-shaped cannula, distal cannula, and vessel-sparing cannula. I've got pictures of all these, so I'm going to come back to them. So this is a sort of classic Y-shaped cannula, or as we refer to it, the legmo cannula. So you've got your main cannula coming in, going up to the abdominal, chest, head, neck, and then you take a side arm and put it down the legs. Now, this is all very well, but it's fairly small. You can't measure the flow down there. So what we've been using for about the last 10 years is a neonatal arterial cannula that you put towards the foot and connect that up with some standard 1/4-inch tubing, and then you can put your flow probe on that. You can actually measure the flow into that leg, and whereas in the past you were trying to sort of do it with sums, if you measured your drainage and then what was going down the arterial side, the difference between the two was what was going down the leg, which wasn't necessarily precise, but was only ever about 200 mils through a cannula like that, whereas now we're getting 400, 500, 600 mils, and we've had less leg issues. To help you further decide whether you need this, you can use NIRS. So this is NIRS on calves of both legs. This was the cannulated leg immediately after going on. Sats were around about the 40 mark. We put in the additional leg mode cannula and the sats improved very dramatically. And that was the flow we were getting down that leg. So this is a big adult, you know, we were giving him 5 litres of total flow, of which 1 litre was into that leg. And again, you can change that. You can put a gate clamp on and tighten it up and get the balance for exactly what you want systemically and what you want down the leg. You can put a cannula in distally. This is an enormous big incision. Not proud of this one. But you've got to remember, you've got a cannula already including that artery, so finding it can be very difficult. And actually this was just after the first iPhone was released, and we've got Grey's Anatomy on the iPhone. The guy doing it was very proud of his new iPhone, and I used nice anatomical pictures to help find this. Sadly, this lady lost her leg. Not this one, but this one. And she had a balloon pump in there, and she got a problem with that, got compartment syndrome of her calf, and ultimately needed above-knee amputation. If you've got a bit of time, you can do a vessel sparing cannulation, so you've got the artery here or here, and you sew a bit of graft on. It could be Dacron, Gore-Tex. If you've got something you've used in the original procedure, stick that on, and then put your cannula down. That allows blood to go to the chest and to the leg. You can actually get away with it, rid of the cannula altogether. So if you've got a 1/4 inch connector, it'll go onto an 8mm Dacron graft. If you've got a 3/8 connector, it'll go beautifully onto a 10mm graft. And then you get rid of all the resistance from the cannula that you don't need. The only downside in this, it's a bit fiddly, especially if you're doing it in an emergency. And what we've seen is you get all the flow just going down to the legs. So if you've got that, what you do is just put a pulmonary, sort of a femoral artery band, just to constrict the flow into that leg a little bit and push your blood more systemically. Now, VA ECMO, it works, it makes a big difference if you need it, but it's not without its risk. And one of the problems is if you increase your flows, then you increase the work of the heart. You're increasing the afterload, you're reducing the preload, and the heart doesn't actually like it. And for a brief period, people said, oh, I don't know what you're doing with that VA ECMO, it's rubbish. You're actually destroying the heart. That's not true, but you have to remember for successful VA ECMO, you need to think about how you're going to offload that ventricle. And I think that falls on the realm of cannulation. So there's various things you can do. You can do your drug manipulation. So we get rid of most of the inotropes when you go into VA ECMO, you don't need them, but we will keep a bit of milrinone, some inodilator running to try and reduce the afterload to improve your perfusion and improve the heart. You can play about with the ventilation, often a high peak, low tidal volume strategy helps, and then you can use ECMO and other things to help unload the heart. These are all more applicable to your bigger patients. Obviously you don't get balloon pumps for infants. And one of the things people seem to struggle with them, they know about balloon pumps, they use balloon pumps, but they get confused about it only works if you're cannulated in certain places. It doesn't. So this patient is cannulated from the, say, would unlikely be the carotid, maybe the axillary artery, something like that. The blood's coming in, the balloon's inflated in diastole, you get some blood going down, increased blood going down in the coronaries, and then when the heart wants to eject in systole, the balloon goes down. We all know that. And then blood goes around the systemic circulation. People think, oh, well, it doesn't work from the femorals, but it does. Because in diastole, the balloon's open, so it protects the heart from the increased afterload and stops excess blood into here. You might suffer a little bit from coronary perfusion, but it prevents that distending force when the heart's at its most vulnerable. And then again, in systole, balloon goes down and the heart can eject a bit now. So it works in both situations. And there is evidence that it makes a difference. So meta-analysis, and it shows that if you combine ECMO and a balloon pump, you get a reduction in hospital mortality. If you want to go a little bit more expensive, people have done this as well, empty the LV on ECMO. This is the impeller. You put it up, cardiologist place it, draws blood from the left ventricle and returns it into the aortic root. Decompresses your heart. And again, it's got various names. ECMella, I think, is the one I quite like. And again, reduced hospital deaths if you combine the two. So and this isn't that you get more cardiac output or anything like this. This is all to do with the fact that you're reducing the pressure in the heart and improving your unloading. There's some cheaper options, and these are more applicable to your smaller kids. So do a septostomy. Make sure you're emptying that left atrium. If you've got a big hole, any increased LA pressure will vent across to the RA and come out your cannula. Often if you're going to make a hole, you need to do a stent because it can close very quickly. And then you've got options for doing it outside the heart. This is one option where you put a cannula up from the groin, pop through the septum with a needle, put a wire through, stretch that up, and then drain directly from the left atrium. And again, that works well and can be quite stable, and it's something that most cardiologists can do very quickly. Other options if things are going bad, you can just go straight through the chest into the left ventricle directly. This was a girl we had who had, as mentioned previously, aortic regurgitation, and all her flow was just going backwards through the aortic valve, LV distending, lungs getting increasingly wet and from pulmonary edema, and we tried all our usual venting strategies. It wasn't working, so we ended up putting a big vent, and that it made it better but didn't cure the problem. She was then moved up to Newcastle, one of our paediatric transplant centres, and the first thing they did was took her to the cath lab and put an Amplatz device across her aortic valve, just to close it off, try and rescue the heart. It didn't work. She ended up getting a transplant. Again, a little bit fancy, you can drain your blood direct from the pulmonary artery. There's no valves in the lungs. So you drain from the pulmonary artery beyond the pulmonary valve, you will decompress the left atrium. And the modern generation cannulas are flexible enough to do that. So you can just, under fluoroscopy, put your way around. Rather than aim down the IVC, you turn and go up through the tricuspid pulmonary artery and then feed the cannula around. And it will sit there quite happily, drain blood and empty your heart. This is a fairly new piece of kit. This is the Protect Duo cannula, which is a way of doing this in one cannula. So this is a double lumen pulmonary artery catheter. So again, fluoroscopy placement to place the tip in the pulmonary artery. It drains blood from the right atrium up there and then infuses blood in the pulmonary artery. So it will help the RV. It's a little bit expensive. We pay about £2,000 for our dual lumen cannulas. This is about £4,000.
Is that the adult size?
Yeah, so it's only big. In neonates, the commonest way to put anybody on peripheral ECMO is using the carotids. Babies are great. They've got two big, juicy, plaque-free carotids and two vertebral arteries to help out. And they've also got some nice skin creases to show you where to make an incision. And it doesn't have to be enormous. I've had some babies come to us where you think that the cannulating surgeon was trying to decapitate them. It doesn't need to be like that. So you get in there, you pull the muscle laterally, and the vessels will nicely jump out at you. There's a jugular vein, and there's a carotid artery. Every time I do this, I think I need to take these silly things So get some ties ready to tie your cannula in. You've got marks to show you how depth. Most neonates will be around about the 6 centimetre mark. If it's a bigger neonate, you might want to go down to 7, and a smaller neonate, 5 and a bit. Once you get your cannula, tie off the vessel. Now you can put the elastic in if you want to protect the vessel. You don't need to. I don't think it makes a big difference. And then clamp the vessel, open it up however you want. There's various techniques which I'm saving for tomorrow afternoon. And then get your cannula and just poke it in. Once it's in, tie it in securely. You don't want it coming out. We did move a patient from one centre in the UK where they'd used elastic tie in, which was designed to make the vessel very nice to repair. You didn't need to repair the vessel once the ECMO cannula had fallen out, because you just don't when the baby's dead and leave it like that. So yeah, it's not a recognised technique, and I wouldn't suggest you do it, but it certainly didn't work in that child. The thing was, they didn't actually tell us that's how they did it until the cannula had fallen out. Then just repeat the process for the vein. So get it in, clamp the vein, make your incision, and pop your cannula in. It's no more difficult than that. And that's what your baby looks like on VA ECMO. Try and keep the cannulas with a bit of slack, just so they don't come out. And that's what they look like. Fortunately, this is an old slide. This caused me many a phone call over night time. So that's where that cannula stops, not where the wire stops. All of these cannulas pretty much have now been replaced with cannulas that are wire bound all the way to the tip. So what you see on X-ray is what you get. It's fine there when the dots face on, but if that cannula is slightly rotated, so the dots at the side, people phone the panic, the cannula's coming out, the cannula's coming out. So you get out of bed, you log into the X-ray system, and no, it's not, it's fine. It hasn't moved. In kids, you have some rather unusual procedures that we put them through, and all of which have slight differences to deal about with ECMO. So this, in the last month where I work, has been the most common operation we've done. We've done 5 in a space of 2 weeks. Completely grinds your flow through the ITU to a halt. But stage 1 nodes are dead easy. All your normal rules apply. So you can go VV, double lumen through the neck, if you've got a shunt issue and you just want to support oxygenation. You can go VA, put a cannula in from the neck, just like I've shown you, and one into the carotid. You can do that. That's not an issue. It works well. You can do central cannulation. You've got the whole gamut. It's dead easy. Remember, just because somebody's had a cardiac operation and they've got bad heart doesn't mean to say they need VA. So this is a kid post-Norwood who had a bit of muscle bundle at the bottom of the sano, so they just needed a bit of help with oxygenation. So we put a double lumen in. This is the Origin double lumen, 13 French, and it worked really well. Oxygenate the baby, jobs are good. We had another child after this disappeared off the market because it had problems with glue and gluing it together, that we came up, well, why not just put 2 single lumens in the common atrium, got a big hole in the septum, so we did that, and although they look like they're pointing in the same direction, one is actually on the sort of left-hand side where we're returning blood, and one's more on trying to poke it down towards the IVC, and again that worked fine. Minimal recirculation provided the oxygenation that that child needed. This is the one when we tried to do it again, that way we got it wrong. So it didn't pick up with just a simple double lumen cannula and oxygenation. It was actually, there was a bigger problem with the heart, But then it was very easy just to put another arterial cannula into the arterial side and go VVA. We get all the drainage we want through the double lumen cannula, but we can support it that way. So you have choices. Mentioned this yesterday, there's a new kid on the block, a 13 French right atrial cannula, again, would be good from them. And the performance is very good from early reports out of the US. I'm going to skip this for the next speaker, as I said I would last night. If you're going through the whole course of your single ventricular repair, the next thing you come across is the bidirectional glen. This is where ECMO starts getting a little bit more tricky, because you haven't got easy access now into your collecting chamber, your atrium. Now, kids at this stage are often young. Femoral vessels, as I said yesterday, could be used, but they're a bit small and may well lead to problems. So that route is often out. And again, you can't get into the heart from the top because it doesn't connect there, it goes into the pulmonary artery. So it's a bit of a pain, and often you're left with some sort of central cannulation of the atrium. You can put in various other arterial cannulas. You put the arterial cannula from the top through the carotid if you want, put it into the aorta. It doesn't really matter, but it's the drainage that's the issue. The other thing that happens, as I said, you increase your afterload on ECMO. With this, the cerebral drainage pressure is very dependent on afterload. So if you put the afterload up, put the pressure in the pulmonary artery up, you put the venous pressure in the brain up. And patients with bidirectional glen are very prone to intracerebral bleed. It's got a very bad outcome. So you do often have to think about putting something into that upper circulation preventive. That could be an ECMO cannula, it could just be something small to limit the pressure. At the very least, you need some way of knowing what that pressure is and measure it. You know, make sure it's sensible. You know, it's 12 and not 20. Again, there's other things we've tried with the glen. So this is a patient had already been on central ECMO for about a week, wasn't moving forward. As you can see, there's a sort of whitening out of the left hemithorax there, was probably developing a chest infection. We wanted to get his chest closed, we wanted to prone, we wanted to do good physio. So we opened up the abdomen, didn't actually get in the peritoneal cavity, went round the back, found the IVC, cannulated here. So this cannula comes up from that, just below the liver, up into the right atrium. Gave us really good drainage, peripheral VA cannula from the top, and we were able to get the chest closed quite nicely. The other thing we've tried is putting a dual lumen cannula into the atrium and just doing it that way. And again, that has worked. You only just need to go in, you put it in through the right atrial appendage, and then you can tie that off, and tie the cannula in securely, and that will give you both drainage and return, and get you out of a difficult situation. And then the final stage in this merry journey through univentricular circulations is when you do the fontan. Now fortunately by this time the kid's grown up a bit, he's a bit bigger, so you now have a few options. You can do your standard, if you need respiratory support, top, bottom. The IV cannulas can be used, but you know, often you see the pictures where this is in a straight line. It never is. It's always offset and round the corners, and just where it felt nice to put it rather than making it all look neat. If that's, you can drain top and bottom if you need VA support and infuse back. The problem often here is you're starting to get collateral circulation and all these things that can make it a bit difficult to get in. People are moving forward, as you know, more and more kids are going down the univentricular route, more and more kids therefore get a fontan, and they can fail while waiting transplant. So this is still experimental, although it's been done in animal models, not in adults. So this is work done by Dr. Wang, who works with Joe Swissenberger, who the pair of them came up with the Avalon cannula, and they've modified it slightly. So that's the usual drainage, there and there, and they put little sort of parachute valves on, and the idea being that you insert this, so this is at about the level of the pulmonary artery. Again, you need screening if you've got a big S-bend to get round. So this will drain from the IVC, this will drain from the SVC, and these valves will try and push blood through the pulmonary circulation for your phallic fontan. Very nice idea. Be interesting to see whether they can get it to work. But you can support these patients, some of them at least, with just a dual lumen cannula if you can get it in. Well, I haven't got a slide on it. The problem with any support in, say, a fontan is you lose the atrium, so you lose your compliance chamber. So your ECMO flow is very on, off. And it would be the only time we would put a bladder in a centrifugal circuit, a thing called the beta bladder, and it just irons out those high and low pressures and gives you, overall you get less flow per minute, but you get more consistent flow per minute and probably protects from a bit of hemolysis. Again, we'd give it a go. If we're having problems, it's easier to chop in as an afterthought. And that's me. Any questions?
In your experience, have you used nice talk, doctor.
Thank you.
The thing is, in your experience, have you used a biflow cannula? There's a new cannula available in the market, which is it's a single cannula which can provide the distal infusion.
No.
Any thoughts on that? Is it?
Now I haven't even heard of it. Now you've whetted my appetite. I'm going to be looking it up. And
It's there in the market. It's called a biflow cannula for the distal perfusion.
oh yeah, sorry. Yes, I know what you're talking about now. I haven't tried it for the arterial cannula. It's a very nice idea. I'm not convinced on how secure it would be. I think it's the way you push it in and then pull it back, and it sort of like opens up a back door. I know what you're talking about. I feel like a bit of an idiot. As I say, nice idea. Whether it will work, I don't know. I know the Australians who produced it sort of, oh yeah, it's really, really good. But I think, again, the flow into the leg is difficult to measure and might not be all it's cracked up to be.
But the flow towards the leg was not enough, so
Yeah.
they had to put another distal cannula in there.
Yeah, so it looks just too fiddly. As in femoral cannulation on neck? I would say probably about 8-9 kilos.
And I understand that you have said smaller cannula would do the trick, but what about reperfusion cannula?
Again, because we've used the neonatal arterial cannula, the smallest we've got is 8 French. Of that, you could go down to a 5 French sheath if you had to. Obviously, the smaller the patient, the less flow you need. It's about doing it, but I think if much below that sort of 8-9 kilo mark, it's probably easier just going to the carotids. You can push that if you have to as well, and it's certainly in an emergency. I would be tending to go there rather than a difficult femoral cannulation if you've got a straightforward neck cannulation.
Doctor, you were saying about the dual lumen cannula and 2 drainages. you're accessing the return also as a drainage, right? So we used that twice or thrice, but what we saw was the return port was getting clogged. Did you observe it anywhere?
Now it only will work with the older generation of cannulas where you've got a solid membrane up the middle. The origin has a deflectable balloon, so it kind of closes off itself, so that would happen. So if you're using an Avalon, sorry. If you're using an Avalon, you need you can't really use it all as a drainage. You can only use the drainage as a drainage. You then have to keep a bit of blood flowing in through the inflow, and then you can split that to the arterial. So I don't know, you might end up with 600 flow, of which 100's going down the return and 500 VA. Yeah. Yeah, so no, it's because it's designed with a deflectable membrane, which then just sucks flat and closes off. So that's why you would have gotten the clot.
Going to the glands that you're talking about. Yes, a nasty one. If you manage to stabilize them with going through the peripherally, putting in a neck cannulae, would you then advocate for going central once you've brought a bit of stability?
It depends how stable you are. I mean, it's often these kids just need partial support, and you might be able to get that and not have any problems because you're not asking to pull off a lot of blood, but you're not then pushing a lot back in. And I think, again, I know when I do my tours of the UK, a lot of people are fixated on mils per kilo. So, oh well, we need 100 mils per kilo or 120 mils per kilo, rather than saying, well, actually, we're on 80 mils per kilo. We've got a good mixed venous and we've got a good lactate. That's probably enough. And it's about balancing it. But if you're in trouble and having to push it hard, yes, you would have to open up, especially immediately post-op. The real nightmare scenario is the kid who maybe comes in 3 months down the line, who something's maybe happening and just not quite right, and that is really difficult. Post-operatively, you've got the central option quite easy.
Right, thank you very much. Next we'll move on to our next speaker, Dr. Naga. Let's give him some time to get connected up. Please, for those of you who weren't here when we opened proceedings this morning, please fill out your evaluation forms as we go. They're in your pack. Thank you.
Thanks, Mark. Good morning, everyone. Hope you have enjoyed the workshop as much as I have yesterday. So over the next half an hour or so, we shall look at how we manage patient on the VA ECMO. I personally believe that every patient teaches you a lesson, and you probably agree that some parents try to do that as well. And so I will like to share a few patient stories and try and learn together about VA ECMO. So our goal on cardiac ICU is to optimize oxygen delivery. And we do this by a lot of tricks of reducing oxygen demand and consumption, and also optimizing the ventilation, the fluid balance, correcting anemia, and playing with the cardiac output, preload, afterload, and contractility, and vasoactive agents. And the aim of our friendly cardiac surgeons and interventional cardiologists is to fix the pump in such a way that you're going to optimize the cardiac output and optimize the cardiac oxygen delivery. And if everything fails, we resort to mechanical circulatory support. This is essentially what we do day in and day out on cardiac ICU. And this, you all know it, that the oxygen delivery depends on the cardiac output and hemoglobin and arterial saturations. And in ECMO, we're just dialing in the cardiac output, what we want, or trying to do that. But the optimal HP is essential to optimize the oxygen delivery. So as I said, I'm going to share with you one of our patients last year on PCICU. So this baby was admitted from a peripheral hospital with a postnatal diagnosis of TGA, VSD, and a hypoplastic arch. Underwent arterial switch operation, arch repair, and the VSD, and obviously would have needed a longer bypass run. Returned to the PICU initially on low-dose inotropes, but shortly after arrival had low cardiac output syndrome with hypotension, which was refractory to inotropes. So this is a lovely review by Peter and Malaika, who basically the risk factors for ECMO are younger the age, lower the weight, high inotropic score, and as you can see, the STAT category, which basically reflects the complexity of the cardiac surgery. And our little baby H had a STAT category of 4, which is higher complexity. So what do we, I usually tell trainees that ECMO is a bit like a flight journey. Cannulation is like takeoff. ECMO run is a bit like a taxi, but has its own turbulence with its bleeding and complications. And weaning is more like a landing. And all the decisions about cannulation and management of patient on VA ECMO and decannulation are made by MDT decisions. And as intensivists, you need to, we led or orchestrate these MDT decisions. And the decision to proceed on ECMO cannulation is typically made on a case-to-case basis. And this, for any cardiac program, this is based on the experience and the judgment of the multidisciplinary team. And the timely deployment of ECMO, preempting a cardiac arrest or irreversible end-organ failure is the key to successful cardiac program. So Chris talked about the types of cannulation, and more often than not, post-cardiotomy, you end up doing via chest or central. And our baby H, we had a short MDT, probably the shortest MDT, because it was pretty clear that the patient wouldn't survive without ECMO with a lot of inotropes. So went on VA ECMO. And again, from the same review, so the mortality, the higher risk of mortality depends on how young the baby is, if the body weight is low, if the patient has other comorbidities, if you're very acidotic pre-ECMO and single ventricle physiology, patients do worse. And if you have high inotropic scores and longer CPB, fluid overload, and etc. But what's interesting is if you're stuck on ECMO for more than 7 days, the survival starts dwindling down. So the goal of your VA ECMO is to restore end-organ perfusion and adequate tissue oxygenation and allow myocardial recovery. Obviously, you want to do that without causing more damage to the patient, and in the way damage the brain or the lungs or the limbs. But however, we do need an exit strategy. You will be hearing this all throughout the workshop, but it's important to hear that 100 times, because ECMO is not a treatment. ECMO doesn't cure a disease or fix a problem. All you're doing is buying time, and so that you can think and your team can think about a strategy to pull this patient out of the death's door. So essentially, it's a bridge to recovery in terms of acute reversible illness. It's a bridge to ventricular assist device if you are in cardiac failure, and it's bridge to transplantation if you have an irreversible cardiac or respiratory failure, or a bridge to decision if your prognosis or the disease process is unclear. So what are we doing? We're trying to drain the blood out of the right atrium, decreasing the right atrial pressures, decreasing the RV ejection, and obviously reducing the pulmonary venous return to the left atrium, and in turn reducing the left ventricular end diastolic volume and end diastolic pressure. And this is to allow myocardial rest and allow coronary blood flow and aid recovery. And in order to do that, you need to get good flows, and that changes from 100 kilo patient to 2.5 kilo patient. And you adapt based on the patient physiology. For shunts and single ventricle, they need higher flows than the biventricular circulation. And if you have a septic patient, flows as high as 200 mils per kilo per minute has been reported. And in order to get these flows, we need the friendly surgeons again to get the cannulas or the best cannulas in the best position. However, as Chris talked about, one of the issues with VA ECMO is LV distension, this is because of the combination of high afterload and also if the aortic valve fails to open, you're continuously getting the venous return from the Thebasian veins and the bronchial veins, which fills up your LV and it distends. We don't have the fancy impellers or the balloon pumps in our size population, so we rely on initially on ionodilators like milrinone to keep the afterload lower. Otherwise, as Chris said, septostomy, LA vent, or rarely LV vent. And then while in the taxi mode, we just don't sit and watch TV or movies, but we monitor this patient carefully in terms of the invasive pressures, the NIAS monitoring, the SVO2 lactate, keep on looking for the signs of improvement, and also if the cannulas are migrating with echoes, x-rays, and monitor by the biomarkers of cardiac recovery and also the end organ function. And you want to keep the nutrition of the patient, optimize it as well, because if the patient has to recover from this very critical illness, the nutrition is optimal. And if the gut, more often than not, if you have gut stasis, we do have a low threshold to start some TPN. And then you don't want to have, need to get some neuroimaging as an ultrasound in kids, or if there is any focal neurological deficit, you think about CT scans. And we talked about the complexity of anticoagulation yesterday. So the first question, the bedside nurse or the cardiac surgeon or the cardiologist or the intensivist or any resident on cardiac ICU needs to be thinking about is, why is my patient on ECMO? And you need to be thinking about, doing lots of tests to find out why am I on ECMO, why my patient is on ECMO. So this paper illustrates that residual cardiac lesions are present in one quarter of postoperative patients who require ECMO. And in this paper, only 20% of the residual lesions are detected by the echo. So if the cardiologist is saying the echo is fine, but you should argue, but my patient is not. So that's why intensivists need to advocate for these MDT decisions and discussions. And earlier detection and earlier intervention obviously will improve patient outcomes. So going back to my baby H, so we went ahead and did a CT angiogram to make sure the arch repair was good, because the patient already also had a switch. We wanted to see the coronaries were fine, and that was all fine. So, okay, there's no structural issue, so we just need to fix this function, and we gave a dose of levosimendan. So this is an adult study of 240 patients and 75 post-cardiotomy ECMO. 75% of them received levosimendan, and as you can see, the ECMO weaning failure and 30-day mortality and long-term mortality are better in the levosimendan group. And they advocate for levosimendan because it improves the myocardial function without increasing the myocardial oxygen demand. And this is a paper from Melbourne looking at use of levosimendan in children. and the levosimendan administration was associated with reduced risk of weaning failure and decreased in-hospital mortality. And the hypothesis is that levosimendan restores your calcium homeostasis and has anti-inflammatory properties and also has anti-apoptotic properties. And that's how it probably helps. And more often than not, grown-ups lead the way and children follow. That's the way it should be, right? So this is a French, not always.
We invented respiratory ECMO.
Yeah, that's what I'm saying. Not always. So this is a study. The French group just started a multi-centered randomized controlled trial called Vini-Levo, looking at the use of levosimendan, and hopefully this will give much better evidence. So as we are on ECMO, we do want, it's the key for the patient to come off ECMO is every organ needs to be working as well as the heart recovery going on hand in hand. So we need to look after the lungs of the patient. And the ventilation strategies, unlike venous ECMO, depends a bit on the patient's pathophysiology and underlying cardiac lesion. And usually, you go with a high PEEP, low tidal volume strategy and regular physio and care of the lungs as we normally do. And sometimes the lung recovery may lag behind the cardiac recovery, so we need to be mindful of that. As the heart recovers, and if the lungs are lagging behind, you might get deoxygenated blood going into the coronary perfusion, so you need to titrate your ventilation or adjust your ventilation according to that. And then sometimes you have to use bronchoscopy. This is a patient from UK who was just a run-of-the-mill PPHN, needing ECMO for pulmonary hypertension. And a couple of days later, that was the echo with the right-sided lung collapse. So we did a bronchoscopy, and what we found was a suction catheter stuck in the right main bronchus. So that was retrieved. So obviously, we're not doing bronchoscopy to fish out these things, but Kamath et al. Reported that bronchoscopy is quite safe, and it allows diagnosis of any infection or removal of secretion, management of atelectasis, and diagnosis of any problems with the airways like malacia, and sometimes you can give surfactant under vision as well. And the risks, the benefits outweigh the risks in this patient group. And going back to the baby H who had levosimendan for about a couple of days, we tend to do a small dose of 0.1 to 0.2 mics per kilo per hour over 48 hours, and this patient got decannulated 5 days later. I think Kesava is going to talk about weaning in VA ECMO, but if my patients fail to wean, again, you need to think about why am I failing to wean, or why my patient is failing to wean. So this is one of the patients from UK as well. Bidirectional Glenn ECMO was instigated for hypoxia, failed to wean, went to the cath lab. There was a big decompressing vein, stealing the blood from the Glenn circulation. That was coiled. We tried again, but failed again. Went back to the cath lab, another decompressing vein. That was coiled. And some of them were balloon occluded. But unfortunately, we tried and tried. The PA pressures were very high, and had to revert back to the BT shunt. And so that was it. So, and sometimes a conventional strategy, or one size doesn't fit all. You have to titrate your VA ECMO management based on the pathophysiology. This is another patient of a 2-month-old girl, Epstein's anomaly with a dysplastic mitral valve. We did a mechanical mitral valve replacement at 2 months using a aortic valve in a reverse direction, and the patient needed ECMO for about 90 hours, stayed on ICU for 3 weeks, and discharged to the HDU on heparin infusion. But comes back moribund in respiratory distress, and that's the echo showing mitral valve inflow gradient. And needed an emergency ECLS, as in VA ECMO, as you can see the lungs flooded, and the X-ray was pretty much similar even before going on ECMO. And then we went to the fluoroscopy suite. As you can see there, I don't know if it projects well, these are the mitral valve leaflets. They're supposed to flutter or move around, and they're fixed, and they're hardly moving. And so patient went back to the OR, and an extensive clot was removed. And came back again on ECMO, and we wanted to keep the ejection going, so we used lower flows and higher anti-10As and ACTs so that there's no more clot again on the mechanical valve. And to allow ejection, we ran in low-dose epinephrine to keep the valve moving. And and then over the course of the ECMO, the function improved, and as you can see, nice movement of the valve on that echo. So yes, mortality in mitral valve replacement in under 2 years is very high, and thrombotic obstruction is what causes the high mortality. Thrombolysis is used in adults, but we can't do that in kids, and we used in ECLS and thrombectomy. And this, I presented this in EuroELSO Barcelona, and that's the patient's echo after coming off the ECMO. And briefly about ECPR, the ECPR outcomes are much better in children, and possibly because we do more often in in-house patients in the PICU environment rather than trying to do cannulas on the road. So, like as in some adult groups. There are significantly shorter times to CPR to ECMO will help, and the cannulation strategies are more often in neck rather than the femoral is probably one of the contributory things. But for a successful ECPR, it needs to be instigated very soon, and you need to have good resources and team available straight away. And the outcome for the ECPR is pretty poor. Anyway, I mean about 33%, and that's in children, neonates, as well as in the pediatric. And then with the sepsis patients, there's again a debate about peripheral versus central. Peripheral, people who advocate for peripheral say that there's more bleeding, more messy with central in a septic patient, so peripheral is better. But McLaren group showed that given the flows required is quite high, they actually advocate for central cannulation, and flows as high as 200 mils per kilo per minute has been used, and their survival to decannulation was 80%, and to discharge was about 75%. This patient I briefly spoke to you about before, with the septic shock initially on peripheral cannulation, went to the central cannulation, and then was decannulated 5 days later. And this boy is now, this was 15 when he was on ECMO, and he's 22 now, and he goes around UK talking about ECMO. And that was a really good save. And then briefly about our survival at SKMC. Over the last 3 calendar years, we had 41 post-cardiotomy patients. 22 of 41 survived, which is up, similar to the international standard or a bit better. And that's showing the stat categories and survival. And more often than not, hypoplastic group or single ventricle need ECMO post-cardiotomy. And this is another paper showing the same, that the single ventricle patients do end up on ECMO, and pre-ECMO acidosis, low birth weight are the risk factors. And again, in single ventricle patients, if the ECMO if you are needing to do ECMO for more than 8 days, the survival is very poor. So I'll just finish up with another case. This is a 20-month-old who, from UK again, presented with just cough and fever. We thought it's a flu. When we did an X-ray, that was the X-ray, and came from the peripheral hospital to our unit in UK, and was hypoxic, not responding to oscillation. Inotropes were going up, so we went ahead and put the VA ECMO on. And then the X-ray was, as you can get, it's white out all throughout. And it was a conundrum. The patient's inflammatory markers were very low, and the only thing we found was a bit of cardiac dysfunction and a huge liver, and nothing else on examination. We sent a battery of tests, and then our friendly radiologist comes along and says, hey, there's something happening on the humerus. And we were like, what are we going to do about the humerus on ECMO? And then he said, there's some lytic lesion there. And then, so we wheeled the patient down to CT scanner, and that's a CT showing mediastinal mass and lytic lesions everywhere. The lytic lesion led to the CT and then mediastinal mass with lymph nodes everywhere. And we were thinking this could be some sort of bad, nasty tumor. And then, so we were wondering about how to diagnose this on ECMO, and then the patient helped us by blowing up a pneumothorax. We used this opportunity to do a thoracotomy, put a chest drain, and at the same time do a lung biopsy. And that actually showed that this is a very rare tumor of pleuropulmonary blastoma, and which is a kind of embryonal rhabdomyosarcoma. And the oncologist wanted to do chemo. We decannulated eventually after 12 days, and chemotherapy was started. So this is the CT before the chemotherapy, and that's the CT after 2 cycles of chemotherapy. And this tumor was so rare that we had to involve an American professor who was specialized in this. And then a few weeks later, we got the staging and everything. And this patient's 3-year survival was 12%. So I would like to ask you guys a question. Would you put someone on ECMO if you know that the 3-year survival is 12%? So hold on to that thought. And this is again monitoring. This is something new. People say that non-clinical seizures are common. So some units monitor continuous EEG. And survival is not everything. This is a paper looking at the neurodevelopmental follow-up. Most of these kids have cognitive delays, gross motor, skill delay. And the worst outcomes are in children with when the cannulation is at older age, or more cardiac procedures and operations as well as catheterizations, and 45% of them had some sort of CNS injury on radiological imaging. And ECMO takes teamwork, so obviously it is life-saving. It does need an exit strategy. And obviously keep asking the question, why is my patient on ECMO? And use specific tailored strategy based on the patient physiology. So I hope you have thought about the answer. Would you put the patient on ECMO if you have known there's a 12%?
Let's have a poll. Put your hands up if you would put the patient on, knowing that there's 12% 3-year survival.
Yeah, it took about 2 months to get this answer, but if our professor was in my hospital...
One hand up.
Yeah?
Must have 2.
Okay. Yeah, but unfortunately we did. But fortunately, this patient survived for a few more years, got to see her baby brother, and had a good quality of life. So maybe we should. I don't know. Thank you very much.
Thank you, Dr. Naga. Very entertaining. So we've got time for questions before we break for coffee.
Oh, yes, questions. I was running away for coffee. coffee, airway, breathing, circulation, isn't it?
Thank you. This is a great presentation. This is a question for me. The question is about the mechanical ventilation and VA ECMO. Like what you said, is maybe one size does not fit all. The resting principle of the lung doesn't apply very much on VA. If you have very sick lung, you can probably go with this conservative approach and try to protect the lung. But if you are thinking of a short run and the lung is not really that sick, did not get flooded or not really insulted, probably it's better to have a patient on reasonable settings so it will help you in the weaning process. Do you agree with this?
I completely agree with it. You know, it depends on the patient's physiology and the status of the lungs. But sometimes, as soon as you put the patient on ECMO, the lungs do get wiped out, and your compliance does go down in some patients. There, you got to use lung protective strategies. But as you know, and sometimes in the single ventricle patients or the shunts, you are using higher flows. You want to ventilate them harder because there is some. You want some oxygen going there as well. So yeah, ventilation is completely different to a VV ECMO in a VA ECMO, and you probably would tailor that to the patient-specific strategy.
My other comment is about your last question. It's an ethical dilemma where you put this patient on ECMO or not. It just comes to the concept of utility. So you need to answer what you're trying to achieve first before you can decide. Like what you said, maybe talking about 12% 3-year survival, maybe this patient will survive longer, you don't know that. And if the family in agreement that you're going to live for another 6 months or 1 year as a reasonable life, it might be worth it. So every case should be discussed separately.
Absolutely. I mean, this also depends on whether I'm in Timbuktu or Johns Hopkins, you know, I mean, and also it also depends on the resources and everything else. So, I mean, we didn't know we put the patient on ECMO, and that's where one of the indications of ECMO is bridge to decision when the prognosis is unclear. That's why I selected this case. So when you are not sure, you go on, then do a brainstorming, get your team together, talk to each other, have a time, and then talk to the family, and then take it from there. But yes, these decisions are, you know, I mean, it's much nicer to do a talk on this, and it's easy, but it's not very easy on the bedside on the units.
So one of the relative contraindications for ECMO is advanced malignancy. So you know the diagnosis, okay, you should talk carefully about it, okay, shall you go for ECMO or not? But if you don't know what is the histopathology report of the mass itself, you are in a different path. You should proceed for ECMO whenever indicated, okay, and then think about what is next. Now, knowing that the patient is having, you know, malignancy, for example, mediastinal mass syndrome, of course you will proceed for VA ECMO to salvage the case. But if you know the diagnosis from the beginning that is related to malignancy, I'm not going to proceed with the intervention itself. Now remember that also another side that we should take care of is the chemotherapy is also thrombogenic, okay? Besides the thrombogenicity of the malignancy itself. So you should know also you have to take care of the circuit, what are the possible complications, all right? And we should be very transparent with the patient's family. That is this is the outcome of the malignancy. This is are the possible complications of the ECMO itself, and then probably either proceed with or you just withdraw the ECMO itself when the parameters are not promising. So things are not easy, and I think it's a multidisciplinary meeting from all panel, including ICU, surgeons, patient relation, family. So everything should be documented, and things will be more clear.
Absolutely, I couldn't agree more. And this talk I did as a trainee in one of the UK meetings, I think in 2013 or 2012, I can't remember. And I asked the same question, and none of the intensivists said that they will put this baby on ECMO. And probably if we had known, we wouldn't have put this patient on ECMO as well. But it happens that the patient came off ECMO 12 days later, and then the patient had a survival and the follow-up for a good quality of life for an year. Then I started to think, so is that 1 year worth of 12 days of spending the resources on this patient, but we always do on the sick hypoplas or sick. So I'm just saying this is a question. I don't have the right answer. I'm not saying we should or we not. We don't. But we always need to have a roundtable discussion. These are the ethical dilemmas we always have. I just wanted to go away with some sort of questions in your mind when you go back from this talk, rather than answers. Yes. Absolutely. Absolutely.
Decisions are not easy, and there are always ethical dilemmas with every case.
Couldn't agree more.
So that's why multidisciplinary meeting, including the primary physicians, the surgeons, the ECMO consultants, social relations, social support as well, family, to understand the sequences of every decision.
Yeah, absolutely. No.
Oncologists, of course. No, they'll see support, patient. No, I know the trick from.
Yeah.
Oncologists, everything is possible, right?
What about them is something great?
So septic shock with multi-organ failure, mortality 90%, they say yes, continue or support to the patient because tumor is salvageable.
Yeah, we don't know. So
like Dr. Nada was mentioning, but for surgeons, everything is possible.
Yes. So Mark, would you have put this patient on ECMO if you have known 12%?
Because the prognosis wasn't clear.
Absolutely.
Okay.
Okay.
You very much.
Thank you, guys.
Good morning, everybody. We've had excellent talks this morning. Some of it may be a repetition, but please bear with me. Okay, so what are we going to cover in this talk? It's important to understand the physiology of VA ECMO, to understand how to wean a patient from VA ECMO. It's different to weaning from VV ECMO. How to recognize that the heart is recovering, how to judge if the recovery is good enough to come off ECMO, talk about some criteria for decannulation, logistics of the decannulation procedure, and post-decannulation care. So I think we've all bored you with this slide probably, or similar slide. So in VA ECMO, we drain the blood from the venous side, and after oxygenation, we return it to the arterial side. Important thing to recognize with the VA ECMO circuit is that the circuit is parallel to the patient's native circulation. You can think of the right atrium is like a tank from which the ECMO pump is sucking, but also the native heart is also sucking from the same tank. Okay, so if you increase the ECMO flow, less blood will be going through the heart. Think of a patient who goes on ECMO, via ECMO. Usually the patient has severe myocardial dysfunction, is the main reason we put the patient on ECMO. So the heart, which is one of the pumps draining from the right atrium, is sluggish and lazy, so not sucking that well. Okay, so most of the blood will keep going through the ECMO circuit in that scenario. And as the heart recovers, what will happen is the heart will start pumping more effectively, so it will start sucking a bit more from the right atrium, so you will start to see pulsatility in the blood, in the arterial trace. Because the ECMO flow is continuous, whatever pulsatility you see is an indication of the stroke volume that the heart is producing. Okay, important thing to recognize that the arterial blood gas that you take from the patient is a mixture of the blood coming from the ECMO circuit and that is pumped from the heart. They mix together, and if you have an arterial line, you'll probably see a mixture of that. ECMO circuit is very efficient. So the oxygen, the PaO2 for example, after the oxygenator would be in the range of 250, 350, even 400, depending on how much FiO2 you're using. But in a patient, you know, the PaO2 of the blood coming from the left atrium, especially if the patient is on rest setting, will not be that high, okay? So initially, when most of the blood flow is coming from ECMO, the blood gas in the patient would be reflective of what is coming off the ECMO circuit. As the heart starts recovering and pumping more, you would actually see that the PaO2 would go down. Okay, that's an important indication that the heart is starting to recover. Okay, so this was very well described this morning. So you put the patient when the patient is having compromised or showing signs of compromised oxygen delivery to the tissues on optimal medical management. Then you have to plan the circuit in such a way that you can provide enough flow that that particular patient needs. You wean off the vasoactive support as soon as the patient is on ECMO, because your aim is to minimize myocardial oxygen consumption and rest the heart. You monitor the delivery of oxygen throughout the ECMO, when the patient is on ECMO. And when the native heart starts to recover, then you start weaning the ECMO. So this yesterday and today we went through this. The body has a luxury of blood supply. Oxygen delivery to the tissues is usually 4 to 5 times of what is required. So the mixed venous saturation is about 75% in a normal person. The critical mixed venous saturation below which the tissues would become hypoxic is 50. So when you are on ECMO, you're aiming for about 66% mixed venous saturation, which would give a ratio of delivery to consumption of oxygen of 3:1. One important thing to recognize is that a lot of patients with respiratory ECMO, the pediatric age group, are being managed on VA ECMO. This is from the ELSO data. So as you can see, almost 60% of the neonates requiring respiratory ECMO are managed with VA ECMO rather than VV ECMO. For the most probable reason is that we don't have good double lumen cannulas that can cope with the centrifugal pumps. Similarly, in pediatrics also, the use of VV ECMO for respiratory failure is going up, but as of 2015, still 50% of the patients were being managed on VA ECMO. So how to protect the myocardium? This is very, very important. During the ECMO run, we have to wean the inotropes as soon as possible to reduce the myocardial oxygen consumption. If the blood pressure is high and if there is any indication that the systemic vascular resistance is high, you should also consider giving vasodilators. Monitor the patient closely for left heart dilatation or distension. Where the VA ECMO increases the afterload. So sometimes if the myocardial dysfunction is so severe, the heart may not be able to eject against this afterload, and the left ventricle may start distending, which will increase the ventricular end diastolic pressure, which will have an impact on myocardial perfusion. We want to protect the heart by good coronary blood flow. So it's really important to keep an eye on this. So you should be thinking about echo as soon as the patient is on ECMO, maybe repeat it in a few hours and look for signs of left heart distension. And if that happens, you need to intervene. You need to unload the left side. So you have to keep the ventilation in such a way that there isn't a significant pulmonary venous desaturation. You have to give some ventilation if possible, so that the blood, if it's ejected from the heart, is reasonably oxygenated. If any arrhythmia is ongoing, again you have to control it to minimize the oxygen consumption. And the most importantly, especially if it's a post-cardiotomy cardiac surgery patient, you need to think about residual lesions. So as Naga alluded to, echocardiography will not be good enough. It's nothing to do with the skill of the cardiologist. It's just the patient is on ECMO, and you know, the ECMO, being on ECMO itself has an impact on the assessment that it can do, because the blood flow through the pulmonary arteries, for example, will not be that much and so on. So cross-sectional imaging, CT or cardiac catheter is definitely indicated if it is not clear that there is no residual lesions. How do we know that the heart is starting to recover? So as I said before, as the heart's myocardial function starts improving, there will be some ejection, so you will start seeing the pulsatility and increasing pulsatility, in that the systolic pressure and the pulse pressure would start going up. You may see improving contractility if you're doing echo. For a patient on VA ECMO, you should probably do echo almost every day. And you would see that the gap between the post-oxy gas, which most centers do it at least once or twice a day to monitor the oxygenator function, you would see that the gap between the post-oxy gas and the patient's gas will widen, because as I said, when heart is pumping more blood, the blood coming off the heart is not as well oxygenated as the post-oxy blood. So you would start seeing PaO2 kind of dropping a bit, and the gap between the post-oxy PaO2 and patient's PaO2 widen. If you have end-tidal carbon dioxide monitoring on, you would see the gap between the arterial PaCO2 and the end-tidal CO2 going down, because more blood is now going through the lungs. And if you wean the support, the hemodynamics will be maintained. So this is what we're talking about. This, if the lungs are collapsed or lungs are wiped out and not oxygenation through lungs is very impaired, then sometimes you can have occult hypoxemia to the blood supply to the heart. This is because if the pulmonary venous blood coming back is very desaturated, even if the heart is ejecting a little bit, it could cause myocardial hypoxemia. It's not easy to detect. This one, if the heart is ejecting a lot, then you would see desaturation in the nurse monitoring and the pulse oximeter in the right hand and so on. But if it is not that well ejecting, it's difficult to detect. So when to consider weaning, you need to exclude all the residual lesions or make sure that the residual lesions are not hemodynamically significant. Then you need to think if there's been enough time for the myocardial recovery. We know, for example, if the patient had a myocardial stun after a bypass, it's about 3 to 5 days run. So there's no point in trying to wean the patient in the first 3 days, so just let the heart rest and give it enough time. If it's myocarditis, for example, it could take a bit longer. So you need to consider what the underlying diagnosis is and have a think about whether there has been adequate time for the heart to recover. Has the end organs impaired? Because sometimes the patient was in low cardiac output state beforehand, there was renal dysfunction, liver dysfunction and so on, if they have resolved. And again, lung dysfunction could be there, especially if there was LV distension and aortic valve wasn't opening. You may get pulmonary edema pretty quickly. Within few hours, you could get a whiteout. And then think about, are there any signs of myocardial recovery? Has the pulse pressure gone up? Is it now 20% of the systolic blood pressure? Is the echocardiography showing any increase in the ventricular contractility? And has there been a drop in the patient's PaO2 in the last few days, suggesting that there is more ejection from the heart? So important things to consider before weaning. If you had an LA vent which was decompressing, if you think the myocardial recovery is reasonable, then you should think about taking it out to enable loading of the left side of the heart. Some patients with single ventricle and palliative procedures may have a BT shunt. Some centers clip the BT shunt to prevent drain into, like runoff into the pulmonary arteries. Most of the centers are not doing it now. Mostly we increase the flow to 150 to 200 mLs per kilo per minute to compensate for the runoff from the shunt. But if the shunt was clipped, sometimes even increasing the flow, the shunt may be too big and you may end up partially clipping it or completely clipping it. You need to remember this, and you need to think if it's been clipped and whether it has to be removed before because otherwise the pulmonary blood flow will be low and you will not be able to wean the patient, and you would be thinking why. Important thing to note, the cardiac biomarkers, the BNP and the troponin, are not good predictors of weaning in the first week. So, they will be definitely high. That shouldn't prevent you from weaning the patient if you see other signs of myocardial recovery. Dr. Naga also spoke about Levsamendon. There are a lot of case series which seem to suggest that in cardiogenic shock, giving a dose of Levsamendon may improve the chance of weaning from ECMO. It has got a lot of beneficial physiological effects. For example, it doesn't increase the myocardial oxygen consumption because it sensitizes the troponin to the calcium. It causes vasodilation and lowers the SVR, which reduces the myocardial work and myocardial oxygen demand. And apparently, it also causes afferent arteriolar dilatation and increased blood flow to the kidneys and increased GFR. So all these are beneficial effects. And in SKMC, when I was there, if the patient didn't have any residual lesions and if it was just myocardial dysfunction, we almost always loaded them with Levsamendon, usually over 24-48 hours. So if you start seeing signs of myocardial recovery, then you should think about how to optimize the circulatory system to kind of think about weaning and decannulating. This slide, I got it from the circulation. It gives you a nice idea. Think about the right ventricle, think about the left ventricle. Is there enough preload to the right ventricle? Is there enough preload to the left ventricle? Which may be because there's pulmonary hypertension, so you may think about inhaled nitric oxide to lower the afterload to the right ventricle and improve the preload to the left ventricle. Think about inotropy, Levsamendon load. What other inotropes you may want to add to support the weaning process. So if there is L event, think about taking it out. If you have LA decompression through impella or something like that, turn down the flows on the impella to load the heart a bit, and so on. And the other thing is to optimize the mechanical ventilation and assess the lung function also. So there are a number of different ways of weaning, and different centers have different protocols and policies. So I'm just describing what I'm used to in the UK and in the SKMC. So here we used to do a load flow trial as soon as we start seeing myocardial recovery. We kind of, in the first thing in the morning with the MDT, like the cardiologist and cardiac surgeon intensivist together, lowered the flow down to 50% of the target gradually over half an hour or so, adjust the ventilation to reasonable setting, and you could observe the patient for hemodynamics, perfusion and so on for half an hour. You could do an echo because now you will be loading the heart a bit more because you've reduced the ECMO flow. So it's important to recognize the echo parameters depend on loading of the heart. So if the ECMO flow is too high, the function will be crap. Okay, so you have to lower the flows and load the heart to see whether the myocardium is recovering. Look for what happens to the CVP. If there is significant myocardial dysfunction, the CVP may jump up when you reduce the flow. Pulse pressure should go up when you decrease the flow. And also you can have an assessment of lung function by measuring PaO to FiO2 ratio. So if you see promising signs, then you could think about doing a prolonged low flow trial. The idea is that you want to have more confidence in the myocardial recovery. So you need to be really confident, because if you take the patient off the ECMO, recannulation may be technically challenging. So this is usually done overnight in centers that I worked. So what you would do is you would start inotropic support, probably milrinone or some inodilator and low dose epinephrine to support myocardial function. Wean the flow gradually over to 50% of the target, adjust the ventilation, optimize the intravascular volume, and you monitor the patient for a good few hours, making sure that the hemodynamics are stable on the minimal support, inotropic support. for a good few hours. If you find that on reducing the flow, you have to give a lot of inotropic support. For example, patient needs epinephrine of 0.15 or 0.2, the CVP jumps up, or there's hemodynamic instability, the blood pressure is lower, then you back off and increase the flows and wait. Because you're going down on the flow, it's worth considering increasing the targets of anticoagulation so that you're preventing the oxygenator from clotting and pump from clotting. So if you wanted to have even more confidence that the patient is going to be okay without ECMO, then you can do what is like a trial of ECMO. Usually it's done with a bridge to keep the blood flow through the ECMO circuit and prevent it from clotting. So what you do is you apply a bridge. Usually you may have to temporarily stop the pump to connect up the bridge. It shouldn't take more than 30 seconds to a minute, especially if your perfusionist is very experienced. And then you can gradually wean the flow to 50% and then to 30%, and then you can clamp off the patient and open the bridge and circulate through the bridge. Then this patient is completely off the ECMO now. So you can optimize the preload, inotropic support and afterload, and monitor the patient for an hour or two. Mainly you're looking at low cardiac output state, clinically, perfusion, pulse pressure, capillary full time, blood pressure, heart rate, lactate, urine output. All these things will give you an idea of how well the heart is coping without ECMO. And if the patient succeeds with this, then you can put the patient back on 50% flow and wait for the surgeon to be there for decannulation. So important thing is when you clamp the cannulas, you cannot keep them clamped for the whole 30 minutes. You need to release them every 5 minutes or so to let the flow and so that there is no stagnation and thrombosis in the cannula. And also it's customary to put half the heparin in the circuit, half the heparin in the patient, and maybe even increase the anticoagulation targets to prevent the cannulas from clotting. So this is what we call weaning with a bridge. So here is the venous drainage. This is the return cannula. You put a bridge between the drainage and the return cannula. So when you've clamped here and you open the bridge, the ECMO is circulating through the bridge, but the patient is off the ECMO. Okay. So how will you judge if the trial off has been successful or not? So it's usually a clinical assessment, echocardiographic assessment. So clinically you want to see that the blood pressure is maintained, there is a good stroke volume, that the pulse pressure is about 25-30% of systolic blood pressure. CVP is lowish, it's not very high. And the patient is not needing too much of inotropic support to maintain this hemodynamics. You need to look at tissue oxygenation parameters. Has the lactate gone up? Has the urine output tailed off? What is the venous saturation? Is it still maintained? We talked about the delivery to oxygen consumption ratio. And you can do an echocardiogram also. The success in adult patients, they suggest that if the ejection fraction is more than 45%, then it's very high chance of success. It's also important to look at pulmonary artery pressures, especially in congenital heart disease. The patients may have pulmonary hypertension, and you need the pulmonary pressures to be reasonable, less than 2/3 systemic. And lung function, you need to look at the oxygenation index or PaO to FiO2 ratio to make sure the patient is not in severe lung dysfunction. This is a new technique that's been described in a few case series where this is pump controlled retrograde flow trial off. So essentially with the centrifugal pumps, if you lower the RPMs gradually, what will happen is the flow will reverse in the ECMO circuit because the systemic blood pressure or the systemic vascular resistance is very high. So the pressure is high in the arterial side, the return cannula side. So the blood will start flowing in the reverse direction. So what you do is you gradually lower the RPM to a level where there is a retrograde flow, and the flow, you decide on how much flow you want to have. That is to prevent the circuit from clotting. So you could say 100 ml or 200 ml or 250 ml depending on the circuit size. And then, this way you don't need to apply the bridge, you don't need to clamp the cannulas. But the disadvantage is now you're having an AV shunt, like arterial to venous shunt. So there will be too much of venous return to the heart. So the myocardial function needs to have recovered enough to cope with that. So I haven't done it myself. Maybe I think Chris, his group has published a case series on this, I think.
I invented it.
Did you? So you can take some opinion from him. So personally, to me, I was considering this in patients, respiratory ECMO patients who are on VA ECMO. Maybe this may be a way forward to, check in terms of, but again, there is a mixture of the arterial blood coming to the venous side. So how we would assess the lung function is a bit difficult. So I myself learning about this now. So alternatives to trial off. So you don't always have to do a trial off. It depends on the center. Like one of the centers I worked, what we used to do is just to wean the flow down to 50%. And then the surgeon comes along and we're ready, open up the sternum and everything. And then you clamp up for 5-10 minutes and you assess how the patient is doing. If the patient is doing okay, then you decannulate. And quite often it worked. And our clinical judgment about the readiness was okay because we had assessed the patient with low flow trial, even had the flow at 50% for good 12 hours or so and everything. So most of the time it succeeded. If the patient didn't cope, then you just abandon the trial and continue the ECMO, and then the surgeon comes back in 48 hours or so to reassess. Okay, echocardiography, I want to say this is vital for VA ECMO and VV ECMO in my opinion, but for VA ECMO, initially after cannulation, you want to see if there's LV distension and aortic valve is opening or not. Sometimes residual lesions may be identified by echocardiogram, and especially for myocardial function, if it's recovering, echo can be helpful. Important to remember that the physiological changes induced by ECMO can alter echocardiographic findings. So if you're doing an echo for function, always think about lowering the flow to load the heart. In terms of respiratory ECMO patients, it can give you an idea on severity of pulmonary hypertension. It can also give you an idea on RV function. These are some of the echocardiographic parameters that adults have reported may be helpful, and if for example, this TAPC is a measure of the right ventricular systolic function. If it's more than 11.5 millimeter, the chances of the patient weaning off ECMO is high, and so on. So for left ventricular function, you could look at ejection fraction, the velocity time integral in the LVOT, and also you could look at like TAPC, the lateral mitral valve annulus peak systolic velocity. So decannulation is usually a decision from MDT, so it involves cardiologist, cardiac surgeon, and intensivist. We need to think, whether it will be one-way wean or if the patient fails after decannulation, whether the patient is for recannulation. If that is the case, then you need to keep the circuit recirculating so that you can put the patient quickly back on ECMO or have another circuit primed and ready. This may be done in PQ or operating room. Most of the time it's done in PQ. You need to prepare for it. You need to request blood products, declutter the room, have appropriate personnel informed and available. Think about prophylactic antibiotics, analgesia. So chest is usually left open if you have central cannulation for a period of time. Vessel reconstruction is controversial. There's been no difference found in terms of neurological outcome, whether it's ligated or reconstructed. If you're using peripheral ECMO cannulation, then you may need to think about how to control the bleeding when you take the cannulas out, especially if it's a big cannula. Usually we keep the child sedated and paralyzed and fully ventilated for a period of time to minimize metabolic demand and not to stress the heart too much. In terms of difficulty in weaning, I mean, this is an approach from the adults, ABCD approach. So you could think of in the same manner, like, is there too much afterload? Is there a patient is fluid overloaded, and is there too much preload? Did we not give enough inotropic support? Was there lung dysfunction? And so on. So if you fail to wean, unless you're sure that the myocardium needs a longer time, it's better to go through a checklist like this to make sure you're identifying any areas missed out. So again, when you wean, if you find that the cardiac function has recovered and respiratory function is recovered, then you decannulate. If the cardiac function is recovered but the lung function is not recovered, you could think about converting to VV ECMO. If the respiratory function is recovered, cardiac function hasn't recovered, you could think about WAD, because in single ventricle, for example, you could cut out the oxygenator and convert this into a WAD if the lung function is recovered. And if neither is recovering after a period of time, I would say 7 to 14 days, then you should be thinking about what is the exit strategy, whether they're for transplant or long-term device implantation. So VA ECMO provides cardiopulmonary support. Both heart and lung function should have recovered adequately for weaning. You can look for signs of myocardial recovery. You could do a daily brief low flow trial to assess the degree of myocardial recovery. Trial off, because some surgeons want trial off, like in SKMC, the surgeons felt much more comfortable to decannulate if the patient was successful with a trial off. After decannulation, we have to remember we're left with a critically ill child, because we want to get rid of the ECMO as soon as possible because of the potential complications, bleeding, thrombosis, thromboembolism, and so on. Thank you.
Thank you, Dr. Kesava. We can take questions.
Thank you, Kesava. Can you elaborate more on the opening of the aortic valve and the importance of having coronary perfusion? Do you discover this by the routine echo, or there are signs of it?
Usually the patient will develop pulmonary edema eventually if you give it long enough, because the LA pressure will go up and then the pulmonary edema will manifest. But the thing to notice soon after you go on the ECMO is that there is no pulsatility. An important thing to remember is the scale of the arterial line may be too high because the blood pressure was different before. So you may have to optimize the scale to see if there is any pulsatility at all. If you can see a clear pulsatility, that means the heart is ejecting at least a little bit, and you know that the aortic valve is opening. But if there is no pulsatility, then you need to think about why there is no pulsatility. Sometimes it's just because your flows are supraphysiological. Sometimes RPM is there, and so if you make sure the flow is, say, 80 to 100% of what expected flows for that age, you should be able to see a little bit of pulsatility. And echocardiography, of course, you can look at the aortic valve opening with echo. You should be able to see the aortic valve opening, and the LV diastolic dimension can be measured. Usually after ECMO, you should see the LV kind of collapsing a little bit because not much is going through. But if your LV looks distended, then you may see even MR if the distension is severe. So all these things can help you, but it's clinically keeping an eye out for pulsatility and also looking with the echo, maybe within 1 or 2 hours of going on ECMO to.
And the solution is to vent?
The solution, temporarily, you can give a little bit of inotrope to keep the heart ejecting, but as soon as you're able, then to go for decompression. Yeah. Atrial septostomy is probably the most frequently done method of decompression. Usually, as I think you may need a stent. Especially if it's older kid, you may need a stent to keep it open. The other options are there. If it's sternotomy, then the surgeon may happily put put an L vent. Sometimes they put it when they put the patient on ECMO, even before they come out, they see that the LV is distending, they put an L vent already. So rarely LV vent. If it's an older kid, yeah, balloon pump, Impala, all these things, but I have no experience with that.
Okay, any further questions? All right, thank you very much, Dr. Naga. So now I'd like to invite Dr. Adeeb. Where is he? Ah, yeah, Dr. Adeeb. Dr. Adeeb is now going to talk to us about infection on ECMO.
I'm trying to save the patients.
Thank you. Take the roving lights.
Oh, this one, this one. Good morning, everybody. It was a full day yesterday about VV ECMO and today about VA ECMO. All of my colleagues they did really a great talk about initiation and controlling of this kind of extracorporeal maneuvers to manage our critical patient. I'm going to use the last line of Dr. Kesava now about speaking about after decannulation they leave you with a critically ill child. So to answer the question of Dr. Naja before, shall we put the baby on ECMO or not? We think about this critically ill child. Is he really critically ill and they deserve ECMO? Or is critically ill because the nature of disease and whatever we'll do, we cannot offer any more help. So to put a patient on ECMO and to carry all of this risk to help the patient and complication, I think at the end we should weigh the benefit against the harm of the patient and decide according to this which way we should go. I know it's very relieving for non-intensivists to have the patient on ECMO and give him just a trial, but it is really a big burden in the ICU team, perfusionist, surgeon, if he needs central ECMO, to do it if not needed. So I think the lecture given by Dr. Nada about indication today and contraindication of VA ECMO and VV ECMO is really important, and everyone should think and rethink about decision. After all of this great effort, it will be a very weird presentation. I'm gonna give the home message before I start. Like everyone did the effort in the field, now we should keep our patient healthy and not to die because of our iatrogenic effect. That's mean by infections. Yes, all the procedure and maneuver have a risk of getting infection, but I think this is the only preventable thing that we can help our population to do it. And this is the preventable thing that can save our time and improve the patient prognosis. So to go ahead, my objective, I speak about the prevalence and then risk factor for infection and screening of infection in ECMO, and then we'll pass by some article review during my talk. So all of us know that those population at high risk because of their underlying disease, in addition to our circuits. The prevalence has been reported in the ELSO registry as 11.7%, and the rate of infection is 15 per 1,000 ECMO. If you go back to the kids, the rate will be between 10 to 20 per 1,000 ECMO days, and the nasty organism is cons and candida and pseudomonas. The early surveillance of culture is not the best, and we should know that some single center studies has found that increased days of mechanical ventilation increase the mortality. It's still not clear for us at the start of presentation. By the end it will be clear. The prevalence of infection in our ECMO is multifactorial, and the most important factor that affect is the open chest, transthoracic cannulation, increased bleeding and clot formation, and the number of invasive procedures performed on ECMO. So, interesting study that I found it speaking about neonate and pediatric. The study around 250 neonate in this study, and with all kinds of infections, bacterial, viral, and fungal. And most of them was in VA ECMO, around 400. And primary source, most of these cases was respiratory cause. They studied the outcome in this population and they found bacterial infection represent also 12.5%. And overall time to infection was 5.2 days with a duration of ECMO of 5.4 days. Bloodstream infection has to find to be 5.8 and respiratory 5.7. So in multivariable analysis of this study, they found increased risk of acquired infection during ECMO with a greater number of procedures of cannulation than during the ECMO, and decreased risk of acquired infection in the patient receive ECMO in the neonatal. And the secret behind this is the tight infection control measure in the NICU always, which is a little bit better than PICU. And in this multivariable study, they found that acquired infection in the blood or respiratory or urinary were not independently associated with mortality. All of these clinical factors associated with increased mortality, including all of these problems. The clinical factor independently associated with decreased mortality is the diagnosis of meconium aspiration in this study. And most common site of infection were the respiratory tract infection. It's counted for 11%, followed by blood in 4.4 and urinary tract in 4.2. So we have to be careful about our precautions and application of bundles while we have this patient in ECMO. The interesting that median days of 5.2 days on 5.4 days in ECMO till you get your infection, and 5.2 days from the infection time. Another study to see the effect and the complication of infection on the kids, they found that the frequency also high, and they couldn't recognize any organism in almost half of their cultures, and they did not found any statistical significant relationship between the infection, on the other hand, the mortality and death of say in BICO. The very interesting study that when I review this topic, I found it in the Indian Journal of Thoracic and Cardiovascular Surgery. So their study also shows 6.1% in neonatal infection, and the time the time and duration of ECMO is associated with increased risk of death. Cannulation technique and the circuit of ECMO, they found 25% increase in the effective complication of VA ECMO compared with VB ECMO. And double lumen internal jugular cannula associated with decreased risk of infection in their population. And severity of illness was decided in this study according to the SOFA score. And they found that the sepsis increased the mortality in the ECMO population, and it has been poor prognostic sign on the survival of neonates. So what is the source of infection in ECMO? All of the sources: VAB, bloodstream infection, cannula infection, mediastinitis, COTI, infected pressure source. And they found that again, pneumonia and bloodstream infection was the majority of infection. Just to a quick schedule in their study, the more duration day of ECMO, the more incidence of infection. So if you exceed the days of 12 days, you almost have 100% risk of infection. So maybe part of our infection control management of our ECMO, as mentioned by our colleagues before, revising daily decision of weaning of this patient, taking them off cannula. Before, if you margin with this, then you should think about, are we really helping the patient or getting him really dead with our management? Again, the organism cons is a very nasty organism with Pseudomonas, Enterobacter, and Staphylococcus, followed by Enterococcus. And they have very nice schedule in this study, elaborating all of kind of infection with organism. Like in VAB, they found Pseudomonas, followed by polymicrobial Staph aureus. In cannula infection is E. coli, Enterococcus, Staph epi. Post-sternotomy stenitis, very interesting, fight mainly with Candida, the first organism, followed by Staph epi, and bloodstream with Pseudomonas and Enterococcus. So, what we should do to monitor our infection? So, we have a patient, all of us, since yesterday, we have been hearing that the ECMO circuit will induce the sepsis. So, when I should doubt my infection, what should I think about? So, any increase in our soft score for adult population more than 2, you should think about need to screen for infection. And you should monitor for all of this during ECMO circulation. And I guess most of our perfusionists, nurses, and training fellows, they'll look when they review their patient about if the ECMO machine is work safely, parameter file numbers, ACTs, and anti-factor 10 is normal, and they forget to assess the patient because they feel the patient is well supported and he should be fine in this. And actually we need to go again and think about everything in the patient. We should always use clinical and biomarkers because unfortunately most of our training will deviate with biomarkers and want to see what is the biomarker looks like, forgetting about the clinical examination of the patient, which is a major entity in daily examination of our population in BICU. And I used to say to my training people, if you didn't examine your patient, don't tell me your plan. And if you didn't examine your patient on a daily basis, don't even speak about how we can manage our patient. You should tell me the proper examination and then think about your plan. So you should think about it always, and trust me, every day you examine your patient, every shift you examine your patient, every chance you have it to examine your patient, you're going to have a new finding help you in clinical management. So basic screening for patient who is on ECMO, in addition to our daily work if needed, CBC, liver function test, urinalysis, chest X-ray, culture, it should be enough culture because we keep getting a report, it's a negative culture. Based on what? Based on low probability of getting this infection in poor sample. So we should get a proper sample for our population to get it, especially if we are thinking about getting this patient on fungal culture result after 2 weeks. Endotracheal, don't do it unless there is clinical need by evidence for need of VAB screening. PCT and CRB, what you think about it? Disseminated fungal infection, after you exceed the 12 days or 2 weeks, in third week, keep it in your upper bucket, not even in the lower, in the upper bucket, because you're gonna have to meet this complication in your way. PCT is not the best monitor because all of this factor can result in increasing PCT. So the evidence shows that both PCT and CRB combined assay had very high overall sensitivity, up to 87%, through the specificity of 25.9. So use all the factors, not only one factor. You don't treat with PCT or CRB alone. You treat with clinical examination, hemodynamics, examination, and then use this biomarker to help you. There is no routine data to tell you that you should put patient on antibiotics, and please do not use unless you need. Surprising that when I roam around in ICUs and read the report, like now we're treating every patient with meropenem and vancomycin, and we start to have carbapenem resistant in our PICU population, which is really a very serious sign in our population. So don't use antibiotic only to them. And like now with this high spike of flu, as a physician, pediatrician, everyone is calling us because every child is antibiotic, every fever with antibiotic. So we should be very careful with it. We start to have this weird resistant organism. For open chest, you can consider it as antibiotic prophylaxis as per your hospital guidelines and your ID recommendation. And for cannulation purpose, you just need a single dose, like any procedure before. You didn't need to start antibiotic. Yes, I'm not saying that if your patient is sick and in sepsis is already an antibiotic, that's a different scenario. But for elective cases, please do not abuse antibiotic. This diagram simply mentioning what I have been speaking about in your management and to think about the disseminated fungal infection. Again, consider your biogram and consider consultation if you find the MDR organism in your unit. Keep in mind about the fungal infection. So the antimicrobial dosing is a little challenging, especially in the center who they don't have a specialized pediatric clinical pharmacist, because ECMO affect all of this antibiotic in terms of direct extraction by ECMO circuit and altered clearance, in addition to volume distribution. Find vancomycin to have increased volumes distribution during the ECMO. And this nice diagram can explain to you the dosing in neonate and pediatric in addition to the adult for the most common antibiotic used in pediatric ICU. So here is the talk. And if we want to really to establish unit with ECMO, you should first have infection control unit well established in your hospital to maintain your patient alive. Otherwise, send them please to other hospital. Avoid any hand hygiene should be monitored closely. Avoiding any kind of contamination. Only continuous vaccination should be administered through the ECMO circuit like any tropes. Please use other lines. Sterile practice for all connection like the needle hubs. Chlorhexidine should be used as agent of disinfection. Strict contact isolation. Bad prevention bundle. Daily check to remove unnecessary line and unnecessary connection. And avoid the prolonged TBN. And I guess everyone will be encouraged for enteral feeding. So the key home message, please, sepsis is important complication of ECMO, and it's really #1 killer after the failure of the circuit. High index of suspicion should be always around, based on your clinical examination and then your biomarker. And please, when you do blood culture, take enough amount. You are in ECMO, you are giving a lot of blood product, you are giving a lot of stuff out of the patient. So please, please, and please take enough volume. Otherwise, you're gonna have subclinical infection, negative culture result. In the first study that I showed to you, half of the culture was negative because no enough samples. So take enough sample to send it to your patient. The patient will not die from like an additional 4 mL or 10 mL to screen for it, especially if you look for fungal infection. Early and timely administration of antimicrobial if needed in high-risk population can decrease the morbidity and the mortality. And meticulous infection control practice. These are some references that I use in my talk. And my last message to everyone, those are our future generation. You guys are current heroes. Save them as much as you can from infection. Thank you.
Thank you, Dr. Adeeb. Some questions? Okay, just one. Oh, here we go.
Just a quick comment about fungal infections. I think they're certainly, you're right, they're very important, and one of the reasons why is it's very difficult to get therapeutic levels of antifungal drugs on ECMO, because by their method of action they bind incredibly well to the plastic. So you end up going up and up and up and up, and I think once you get established fungus, you've pretty much had it. I know we've got a very low threshold for starting prophylactic antifungals, especially, you know, we use miconazole, voriconazole for any flus, because we found aspergillus is very common in that patient population, and if you don't treat it early, you don't win.
Well, lucky enough, because we have what is called Gluctomenan test now available to screen for aspergillus in this population. So you can consider it while waiting for fungal culture in 48 hours or 72 hours. You can get this test like this, and it can be to start prophylactic antifungal. And I don't want to make it again another physiology and another after all of this physiology that we talk about. But once you get the disseminated fungal infection, I think you should revise yourself about your circuit and about your ECMO, because without ECMO, disseminated fungal infection is a bad killer in kids. So if you get fungal infection, just revise yourself about every decision in this patient. And go aggressively with the leading by your IDT.
What is your experience about infections among ECMO patients in your unit? So, are you okay with the numbers? Detectable, not detectable? How do you manage to prevent?
I have to say in front of everyone, although I don't want to say, we are abusing the antibiotic. And every time I'm on the service, I came and I found my patient already like Morobinam, vancomycin, prophylactic antifungal started at day 10 without sending a culture, and I start to like mindset my team and changing their practice, and I did everything. They give me numbers with red colors in my patient that infection increase, infection control. So I wrote always the OVR and the center reports. I send it to infection control and I call them to see what's going on. And every time I have to say the truth. As a physician, and including the surgeon, we are the worst in our hand hygiene, because they call us, patient is sick, we run to the patient without wearing our precautions or cleaning our hands, and we transfer them, and we found cons is one of the nasty organisms in our population. So I start to blame my team as a consultant and my middle grade doctors before I blame anyone else. I think the nurses and the provisionists are the most beautiful people in these measures, because even if the patient is sick, they manage to wear their stuff, clean their hands, and they touch the patient. But as for us as a physician, we come just quickly, see what's going on. They put their hand even without washing. And sometimes, like if you saw the hand rubbing, at one day I did a quick test for everyone in the unit. So I bring the alcohol, I have my sheet, I score them. Highest gets scored 6 out of 10. So I think our control measure has been failed. Once we have this accreditation coming from GCI or SABAI or this institute, everyone will learn everything and have everything ready and they do proper. Once you get these visits out, everyone will be lagging behind in their infection control measure. So unfortunately, I have to tell you that our rate is high, and we are taking a strong action. And now I was lucky enough because I get like 24-hour coverage by infection control nurse inside the PIC. And they agreed for this because of risk of the increased rate of infection. And the easiest thing for our colleague in like surgery and anesthesia, they're correlated to central line, not with the ECMO circuit. So the central line that has been inserted by intensivist is the one contaminated, because simply it was sent for the culture first. So all of them will end by collapsing rather than infection in the ECMO circuit. At the end, the patient gets it, whatever the source, the patient will run from the complication.
Thank you, Dr. Adeeb, for a nice talk and a very good comment, Chris. I have a couple of questions. One is, are these ECMO patients getting fungal infections because they are surrounded by plastic, or is it because we throw them nothing less than domestos like meropenem and all these things at them at the first rise of CRP or PCT? And the second thing is, does any of you have the experience of selective gut decontamination and how it affects the infections kind of thing? Thank you.
Answering the first question, I think the abuse of antibiotic is a major source of fungal infection in our population. And maybe the people feel we are throwing a very big machines and big cannulas in our patient. Why we are not covering with proper antibiotic? And then abuse of antibiotic will induce secondary fungal infection. And that was optimal from most of the studies, because they're speaking about 2 weeks of antibiotics and we're going to have the complication. Unless the patient like is immunocompromised patient who is on chemotherapy and has recurrent fungal infection, which is different scenarios, special scenarios. I have no experience with disseminated decontamination. Maybe if anyone has experience, please share it with us.
Yeah. started in all the head.
Yeah, I was going to. So, I mean, I don't have a study as such. When I was a registrar at All the Hair, I wanted to look at this, but never managed to do that. But we had this selective decontamination in the All the Hair, and then at one point that was stopped. I don't know the exact reason why it was stopped, because they used to use tobramycin and some things like that, and some of the drugs they were not available. So what we have seen is once it stopped, the microorganisms or the infections we were getting, that flora were completely different to what nosocomial infections we were getting before. So we wanted to look at it, but we never got. But anecdotally or just by observation, we saw more fungal infections when we didn't decontaminate the gut. But I hope there is a study which comes out.
I just maybe want a question to the surgeon. How far surgeon comfortable not to have the patient on ECMO and not on antibiotic?
I think you've got to be very careful. I get where you're coming from, but every time we get a microbiologist, pure, unless you've cultured it, don't treat. We do stop them, don't get me wrong, but I think you have to be doing it in the right patients and have a low threshold to reinstigate it. I think we'll stop, we'll culture, but any sign of any instability, we've always got a backup plan of what we're going to start, and we'll start that at a drop of a hat. But yeah, you can get away with it, but not for everybody.
Yeah, the interesting thing that, we love the surgeon because they are our backup. Like we're expecting to see this CERS always in every patient on ECMO. And when he see the patient second day in ECMO, and they tell him that I give prophylactic dose at the start. Like somewhere you feel that you are not in the place, and he will not be happy too much with you, and he will request it like by name, start this and this. And again, I tell him I'm gonna write, I do consultation. By the time I write the consultation, the antibiotic started, because he has to get, and he will not leave the patient. So I guess what I want to say in our picture, I think we have to have, like it's the same idea of when they start to walk up, the picture you put yesterday about early mobilization for the patient on ECMO. When we start this concept, everyone, like, you are crazy, like the church will get lost, the can will go out, be careful. And now with more and more picture, you see more practice, you see the people start to be happy and they start to mobilize the patient on ECMO. The same thing about proning. And I guess we need to go to that era in terms of antibiotics abuse to minimize. Because I was surprised, I'll not mention the name or the units or the place. There is a weird antibiotic called avotazobactam. I never heard it in pediatric. I found 2 patients in PICU at one place on this weird antibiotic, and now they have fluoxetine or something like that instead of vancomycin, because this can explain to me, because it has the same effect of vancomycin but no effect on volume of distribution. But to have this weird antibiotic in pediatric and neonate is very weird. That's why I'm just thinking how far we can go in our practice. And really, I never studied infection ECMO before, but when I have been requested to do the talk, it was interesting for me when I go about a lot of articles speaking about it, and how much the culture is negative, how much in fungal infection. Like some studies, the first infection is Candida. Like you can imagine how we are compromising our patient antibiotic. And that's the point that I start saying we should be very careful about decision about the infection control and the abuse of antibiotic.
I just have to make a comment, a counter argument with this. I agree with the principle, the liberal use of antimicrobials can create a problem for us. But also remember who is this patient that we're dealing with. This is a quite serious type of manipulation that we have on the daily basis, not only during the first initiation of ECMO. So the point of starting antimicrobial broadly without a clear evidence in the literature said that you can be safely do it without this antimicrobials, I will make the analogy with any surgery. that now the prophylactic antibiotic, 1 dose or 3 doses, is acceptable practice because they found this has really reduced the chance of the infection. So until we have this answer, I think people will still abuse the antibiotic for those kind of cases because we open the circuit or we open the line multiple times every single day for this kind of patient. So we have to be careful about being very cautious like any other ICU patient. This is a patient in different setup. Thank you.
I guess you have a very nice answer in for your comments when we said abuse. So terminology of abuse is preventable every place in the world. So when we have this antibiotic with terminology of abuse, we should be very careful to avoid this abuse and have the proper use. Even empiric antibiotic, third generation cephalosporin is still empiric antibiotic. It shouldn't be our first choice, is carbapenem the first choice. So we should just review our decision about the antifungal, anti-treatment, antibiotics, and what is the first line always. And maybe the way to establish it with ASD program now in every hospital and worldwide is to sit with the ID people and to teach them what is the meaning of ECMO. Because most of them, they know the general concept, what is ECMO in general, like it's a new machine go to the patient. But what we are doing in daily practice, adjusting cannula, recannulate, having drain, having bridge, having all of this, we should teach them about what we are doing so they can give us the proper advice, and then we can establish our trial and our treatment protocol in our units.
Thank you very much. I think if there's no further questions, we'll move on to our final talk of the morning from Dr. Kesava, who's going to talk about myocarditis.
I was supposed to give this talk tomorrow, but because of change, I'm doing it today. But I think it's definitely better to do it today because it will give a recap on all the topics that we've touched on this morning. That way, the learning will be more embedded. So I was thinking, let's work through a real case of myocarditis that was from literature. So, 12-year-old girl presented with headache, neck pain, nausea, diarrhea, and overall lethargy. She was found to be febrile, tachycardic, and hypotensive on admission. And she was given 20 ml per kilo of normal saline bolus. Following this administration of the saline, the patient started experiencing oxygen desaturation to high 80s, low 90s. And the laboratory tests were back, and the AST was slightly elevated, CRP was normal, troponin was very high. Because of oxygen requirement, chest X-ray was done, and it showed signs of pulmonary edema and normal cardiac sellout. ECG was done because of the high troponin, and it showed ST segment elevation in inferior leads and occasional premature ventricular contractions. And echo transthoracic showed reduced left ventricular systolic function, but normal right ventricular dimensions and systolic function. So the myocarditis is a difficult diagnosis. You need to have a high index of suspicion. If you look at some studies, almost 50% of the patients presenting with myocarditis and cardiac failure received a bolus of fluid because the diagnosis wasn't established. It was suspected initially. So obviously it usually presents with non-specific symptoms, breathlessness, tiredness, lethargy, fever, and so on. So in this case, from the clinical history, you can be fairly certain it's myocarditis, right? You had patient got worse after fluid bolus suggestive of cardiac failure, had high troponin, ECG changes, all these things suggest myocarditis. So if you suspect myocarditis, you should definitely admit the patient to ICU, okay? Because there is a significant chance of sudden deterioration from arrhythmias, progression to cardiogenic shock. It's preferable that the patient is actually transferred as early as possible to a center with ECMO capability. Risk factors for ECMO in myocarditis patients: age less than 2 years, LV ejection fraction less than 30% on initial presentation, and arrhythmias. There's a lot of advances in terms of diagnosis and treatment of myocarditis. I'm not going to cover that, but there is a nice article in the circulation which is open access about pediatric myocarditis and management of pediatric myocarditis, I would definitely recommend. An important change is that you can confirm the diagnosis now with cardiac MRI. You don't need a biopsy to be certain that it is myocarditis. Okay, so she was admitted to ICU, central and peripheral access was obtained, and the patient became hypotensive again. So the intensivist decided to start epinephrine infusion. I mean, what can epinephrine do? Epinephrine can, of course it was started for inotropic support, but all inotropic agents increase the intracellular calcium in the myocardial cells and predispose to arrhythmias. So if sometimes starting inotropes can trigger arrhythmias, unfortunately this happened for this child, where the child started having frequent premature ventricular contractions, and pretty quickly it turned into sustained ventricular tachycardia and cardiac arrest. Resuscitation was started as per PAL's algorithm. So this patient is in cardiac arrest and arrhythmia, so you may get a response for resuscitation and cardioversion and so on, defibrillation. So what about ECPR? Who would activate ECPR for this patient? Yeah, so if you have ECMO capability, then you should be thinking about ECPR. Even when you have a patient with myocarditis and arrhythmia or cardiogenic shock, you should pre-warn the ECMO team to be ready, because it's a significant possibility the patient may need ECPR. Logistics of VA ECMO activation, you have to activate in a timely manner. You need to anticipate which patient may be more prone to need ECMO. And there are risk factors for, for example, in myocarditis, I put 3 risk factors there. Then there is cannulation, ongoing management, weaning, and decannulation. So in terms of ECPR, usually the recommendation is to activate if you don't achieve return of spontaneous circulation within 5 minutes of a witnessed cardiac arrest. So the key word is that if the patient is in ICU or in a ward and the patient has a witnessed cardiac arrest, and if you have ECPR capability, you should activate by 5 minutes if you're not achieving ROSC. Essentially the idea is to get the patient quickly onto ECMO unless you get a return of spontaneous circulation. That is, you start the activation of the ECMO team at 5 minutes. You may not need it, and you may be successful with your resuscitation, but to get the patient onto ECMO on a timely fashion, if you activate early, you will be more successful in getting them on ECMO quickly. So the reason for witnessed cardiac arrest is you don't want to have zero flow time more than 1 or 2 minutes, preferably less than a minute. So ECMO initiation, it's logistically a problem. It's even more a problem in ECPR, because a normal ECMO initiation itself, you need a lot of preparation, and you need to think about the personnel that you need, the equipment that you need, and the environment that you need to make it successful. But in ECPR, actually it involves 2 teams. So you have a team that is resuscitating the patient and providing good CPR, which is essential for good outcomes. If the CPR quality is not good, then you will not have a good neurological outcome. And then they have to coordinate with the ECMO surgeon and the ECMO team who will be cannulating. So what kind of cannulation procedure would be used in a patient in cardiac arrest? If the patient had a sternotomy, obviously it's easier to go through the sternum, but going through the sternum means you may have to interrupt the CPR. But I can tell you quite successfully, we have put many patients on ECMO through chest. As long as the team is working together, you can get very good outcome and minimize the interruptions in the CPR, even with chest cannulation. But usually, if there is ongoing CPR, peripheral cannulation may be preferable, especially if it's an older child. Femoral cannulation may be much more easier because then you don't need to interrupt the CPR. In a young child, you may think about neck cannulation also. So this I already talked about in the previous talk. So when the patient is on ECMO, what we are making sure is that the tissue is receiving enough oxygen, that is the delivery of oxygen to the tissues is well maintained. And this we went through again and again. The predominant determinants of that is hemoglobin and saturation. On ECMO you would have a good saturation, you need to think about hemoglobin. And if the ECMO flow is good enough, then you will have a good cardiac output. This patient for sure is an ECPR situation, so the mode of ECMO will be VA ECMO. So how do we make sure that we deliver enough oxygen to the tissues? You have to look for signs of poor tissue oxygenation. None of these signs or symptoms on their own is reliable indicator of tissue hypoxemia. You have to put together many parameters. In terms of ECMO, you may have a lot more than what you have in a usual intensive care patient. For example, you would have a continuous monitoring of saturation in the drainage limb, which is a good indication of mixed venous saturation if the heart is structurally normal. You may have nurse monitoring, which may also give you more information. So it's important that the outcome of ECMO is better if you institute ECMO within 6 hours of cardiogenic shock. In this case it's CPR, so you need to do it within 30 to 60 minutes of, preferably 30 to 60 minutes. But having said that, you know, I have had experience of even getting them on after 1.5 hours. As long as you've given very good quality CPR, you know, you can get a neurological outcome even if it is delayed, ECMO initiation is delayed. So criteria for myocarditis is the same as any other VA ECMO. When you have hypotension or poor oxygen delivery, despite optimal medical management, then you get the patient on ECMO. I mean, the definition of optimal medical management varies from one institution to the other. There is no universally accepted criteria. So generally it involves reducing metabolic demand, controlling fever, giving sedation, analgesia, and paralysis if required, mechanical ventilation to remove the work of breathing and metabolic demand on the heart, correcting acidosis and hypocalcemia. And in terms of inotropic support, you know, Dr. Nada highlighted that if the inotropic support is substantial, more than 0.2 of AP, then you should be thinking about ECMO. That varies from center to center. I worked in one center where we wouldn't think about ECMO unless the patient is on 0.5 of epinephrine. And other indications, as in this case, cardiac arrest with no return of spontaneous circulation and intractable arrhythmia. Sometimes, you know, I remember one kid, but that was a HOCAM kid, but he had repeated arrhythmias and we gave him like 25 shocks or something like that in 6 hours, and eventually we put him on the ECMO. So intractable arrhythmia is also an indication. We talked about this contraindications. Theoretically, this patient is previously fit and healthy, so shouldn't have any of these contraindications. So what is the strategy of using ECMO? So if the patient is in severe cardiogenic shock and has respiratory failure, then you have to put the patient on VA ECMO. But if the patient is in low cardiac output state with preserved lung function, you could think about putting the patient on you know, just ventricular assist device. I'm not sure how many centers are doing this, but if you had the ability to do it, then you could put you know, a ventricular assist device like Impala, or you know, you can even cannulate through the chest, draining from LA and pumping into aorta. So you may need to use the recovery time for children with myocarditis could be significantly longer. So if they are not recovering quickly, then you may need to think about durable devices and referral for cardiac transplantation. So Dr. Chris talked about all of this. So the main disadvantage of central cannulation, it's usually easy if it is within 10 to 14 days of sternotomy. If you have to do a fresh sternotomy, it may take longer to get the patient on ECMO. But the advantage is you can put larger diameter cannulas, you can get higher flows, and you can vent the left side if required. And also the cannula is usually placed in the ascending aorta or one of the branches in innominate artery or something of that sort, and you would get good oxygenation to every part of the body. The risks are bleeding is a major complication with central, especially if it's post-cardiotomy, and immobility because the cannulas can dislodge easily. Peripheral cannulation, I don't know, the femoral arteries, I mean, minimum of 15 kgs, probably better more than 30 kilos. Then you may be able to get good size cannulas in them. So the carotid artery could be used up until they're 15 to 30 kilos. So what happened to this child? There was no spontaneous, return of spontaneous circulation. The patient became asystolic after, like a few minutes of CPR. ECMO was activated. Femoral cannulation was performed at the bedside using Seldinger technique, and the flow was established. The SVR was a little bit high, so sodium nitroprusside was started to help with better flow. Interesting fact, this is from ELSA database. Most of the children who receive VA ECMO, even up to 18 years of age, the vast majority of them so far reported to ECMO have been cannulated through the carotid artery. So that was surprising for me. This seemed to suggest that maybe the neurological outcome is not as bad as we imagine with the carotid artery cannulation, even in children, to adolescents even. Once you've cannulated the patient on ECMO, it's important to have a team huddle and think about, maybe have a checklist to go through the plan. So for example, it's important to wean the anatropes, vasodilators may be required, when to start heparin, and then you have to have an assessment of echo to see if there is ejection, whether left side decompression is required, and also if you are doing peripheral cannulation, you need to think about limb perfusion, especially in this child because the child was cannulated through femoral artery. I think nowadays it's routine to place a retrograde perfusion cannula to avoid, because before, I remember when I was in Melbourne, we used to kind of monitor the leg and then go for it. But I think most of the time nowadays it's it's routine to place a retrograde perfusion cannula. So this is from Dr. Chris's article actually. I took these pictures. And because it's peripheral cannulation, you need to think about this north-south phenomena. Especially if the lungs are not working well, you may get deoxygenated blood going to brain. So it's important to think about where to monitor your saturation, especially if you have femoral cannulas, you need to monitor it in the right limb, because right arm, so that you know what the saturation of the blood that is going to the brain is. Okay, this is the one I talked about already. So I talked about this. We talked about this multiple times today. So even though there is less preload to the left ventricle, the afterload to the left ventricle goes up on VA ECMO, and sometimes the LV may distend. The consequence of that is you can get EDP going up, affecting myocardial perfusion. Pulmonary edema may occur, and if the stasis could lead to thrombosis also. Usually there will be some ejection because once you are on ECMO, you have a bit of weaning of the inotropes which will lower the SVR, and also the blood pressure will be higher and there will be baroreceptor mediated vasodilation. The heart will get good oxygenated blood and the myocardial function may start improving. There may be correction of metabolic state such as acidosis. So usually there will be ejection, but if the ejection is not there, then you need to think about decompressing the left side, at least monitoring closely for it. So these are the options you have. The most frequent one is septostomy or an LA vent. This is one, I took this image from one of the papers where the pulmonary capillary wedge pressure, which is the left atrial pressure, is so high. The patient was high because the patient was in shock, cardiogenic shock anyway, and when you put the patient on ECMO, it went up a little bit more, and once the impella was implanted, you could see it coming down. So, in this patient, in that paper, I took the history from. After the ECMO was initiated, they did a transesophageal echocardiogram. They found that both ventricle contractility was very low, aortic valve was not opening. So they took the patient for cath lab and did a septostomy. And they used a cutting balloon to open up the atrial septum. So how to protect the myocardium? Once the patient is on ECMO, we need to kind of wean the inotropes, keep the SVR to minimum. Of course, you have to maintain the perfusion pressure. It's really important to maintain the perfusion pressure, but you should, as long as the urine output is maintained and tissue perfusion, lactate and everything is improving, you could, keep it on the lower end of normal. Decompress the left heart, avoid myocardial deoxygenation from respiratory dysfunction, control arrhythmias. So in terms of monitoring the ECMO patient, you have circuit monitoring and you have to think about patient monitoring. So what you're monitoring in this circuit is blood flow, how much ECMO flow is there, and to make sure the circuit is working okay, the pressures are monitored in multiple sites on the circuit, which will give you an idea of how the circuit is working. You need to monitor, especially in VA ECMO, continuous monitoring of the saturation in the venous or the drainage limb is good. It will tell you about the adequacy of the ECMO flow. These are the usual targets. It's important to understand that cannula length, diameter, the configuration of the ECMO circuit itself is not easily modifiable. So if you have to get them right. So you need to have a previous, the perfusionist and the ECMO specialist need to think closely about the configuration of the circuit. That's why preparation is essential. If you had to do it without preparation, you would probably get it wrong. The modifiable features are preload, like if you give volume, always the flow goes up. You can reduce the afterload. The flow will go up in the centrifugal pumps because it's afterload dependent. And the easily controllable one is the RPM. So you can just increase the RPM and the flow will go up. Patient monitoring, so you have to monitor tissue oxygenation, whether we're resting the heart properly, lung function and neurological status. Especially if the patient has had CPR, you need to think about neurological status and how to monitor it. Sometimes we do CT scan in a day or so just to be sure the patient hasn't suffered significant hypoxic ischemic injury. So then we monitor the patient for improving myocardial function, which could take a fair amount of time in a myocarditis patient, usually longer than post-bypass cardiac dysfunction. So what is the outcome for patients who have VA ECMO for cardiac reasons? You can see the neonatal myocarditis is about 50% survival to discharge. Slightly better for pediatric myocarditis, and adult myocarditis is somewhere between pediatrics and neonatal. I was trying to understand the prognosis for this patient. So I would recommend this paper from the German guys. They have a prospective database of pediatric myocarditis patients managed in many of their centers. And this is a paper from their database. So this is myocarditis and cardiomyopathy. As you can see, the survival is around 50 to 60%. Even with prolonged runs, you can see this is the days on ECMO. The myocarditis patients and they tend to do better than other patients who are on ECMO. I think this may be related to availability of destination devices, ventricular assist devices, and transplantation, because the patients who recovered, bridge to recovery in this group of patients was only 43%. The survival was 55 or 60% because some of them got transplants, some of them got ventricular assist devices implanted. So that was a little bit disheartening for me, because right now in UAE we don't have transplant for children and ventricular assist device service.
It's just to interrupt, sorry. It's not totally the case, actually. 12-year-old girl got transplanted from CCAD. So the first case has happened, and we're hoping that we can expand the program. And the other thing to mention is that CCAD have an impeller program. So for larger children, it's possible for us to collaborate with them to use impeller and VAD.
The impeller was being used in SKMC.
It's not now.
It's not now.
No, there's nobody there who can deploy it now.
Okay, so the learning points or summary from myocarditis patients, preferably they should be looked after in a center with ECMO capability, especially if they have risk factors, if they're below 2 years of age, or the ejection fraction is very low in presentation, or they have arrhythmias. Even if they're having premature ventricular contractions or premature atrial contractions, it's important to think about transferring them to ECMO center. So this usual ECMO course is you initiate the ECMO at the right time, usually before the end organs are damaged. So if you're not winning, within few hours of resuscitating the patient with cardiogenic shock, think about ECMO. Once the patient is on ECMO, we need to focus on myocardial protection and keep looking for myocardial recovery. In these patients, it's important to consider exit strategy. I think especially if you're in a country where there isn't a full-fledged transplant or a VAD program, and if you're looking at transferring the patient abroad, then you may have to think about your exit strategy from the beginning. Thank you.
Thank you, Dr. Kesava. Questions?
Thank you, Kesava. As you know, that people who are doing ECMO more often, maybe they will be more courageous to start the ECMO early, and somebody like with myocarditis. Anybody have compared the conservative approach versus ECMO approach to see which one will do better? What I'm trying to say, maybe the ECMO helped to speed up the recovery of the myocardium? Maybe not?
I think the ECMO is basically buying time, enabling the underlying myocarditis to recover. What I didn't talk about was management of the myocarditis, underlying myocarditis. I mean, people use IVIG and anti-inflammatory doses, but more recently, especially with COVID myocarditis, more evidence is accumulating that it is an inflammatory process, and biologicals like anakinra and tocilizumab and all these things can actually speed up the recovery of the myocardium. In terms of ECMO itself, I think the main purpose is to prevent end organ damage and to unload the myocardium. Especially if you are treating with high dose inotropic support, you may be increasing the myocardial oxygen consumption, and you may be causing more damage and delayed recovery. As far as I know, I didn't find any randomized control trial or anything of that sort looking at this aspect. Generally, the ECMO community is not inclined to do randomized control trials for ethical reasons, because most centers feel that ECMO is effective if it is used, and if you select the patient correctly, it's definitely beneficial. In terms of, as I said, unless we do randomized control trials, we wouldn't have that kind of data where delaying the ECMO, or starting ECMO within 6 hours or 24 hours is beneficial or not. But the adult studies, what they say is if you have cardiogenic shock, if you implant ECMO within 6 hours, your outcome is better, but these are all retrospective case series.
So until we have this randomized trial, still it is selfish therapy, somebody who's crashing or not improving or getting worse with time.
I can tell you that the prognosis for children who are crashing and with a high acidosis who go on to ECMO is a lot worse. The further down the pathway you get to multi-organ failure, the less likely the child is to survive intact after ECMO. There's very clear data on that, not just for myocarditis, but every type of cardiac support. So you're better to avoid ECPR, basically, because even that ECPR will bring down your survival as well. So if you are in cardiogenic shock and the indicators are there and you've got high inotropic scores, you have resourced for ECMO, you should implant it early. RCT is very difficult to organize for this group. So yeah, I mean, it's an open question.
I think in terms of myocardial rest, I know that VA ECMO can increase the afterload and so on, but for sure, we know from bypass and other situations with myocardial dysfunction, ECMO does reduce the myocardial oxygen demand, and if you manage the SPR and you minimize the afterload, definitely the heart will recover in those situations much quicker. So I think, in terms of providing myocardial rest itself, I think ECMO is effective. Of course, you have to be mindful of keeping the afterload as low as possible, weaning the inotropes quickly and giving vasodilators if needed and so on, but I'm sure it will help.
Any other questions? Okay. Thank you very much, Dr. Kesava. That was very good. Comprehensive talk.
The CRRT should be stopped and it should be removed, and we have to, the surgeon or the team should plan some other alternative if the patient really needs dialysis, either the peritoneal or chemocare, whatever it is. There should be a plan for that before the plan. So these are the main preparations which we do pre-trial. So for the steps for the trial of now, so everything is ready, the patient is okay, the team set the time for trial off, and now we have to start trial of procedure. For that, the first thing is we have to optimize the ventilation. The patient should be on full ventilation, because usually the patient should be on press mode. Full ventilation, and also once the ventilation is up, you have to disconnect the seat kiosk from the blood. So this one, so this is the first step. Optimize ventilation, disconnect the seat kiosk, and then nothing is going to the bridge. This is quarter. The bridge is quarter.
Yeah, quarter inch.
What if
Putting your quarter inch.
Yes.
Inch, yeah, same. Quarter inch.
Okay.
But whatever cylinder you are connecting with the three-way. So it will run from the three-way.
There will be a connection here with a T-junction like that. So we will put the three-way and fix it. Flush it where?
No, now it's flushing. Now it's running to the patient.
The clamp is open, it's going.
It's going
for 10 seconds.
Yeah, now it's going to the patient. It's already closed.
It's already closed.
It's fine. It's fine, yeah. It's fine.
So this process will continue every 10 minutes until we get, the team is satisfied with the package.
Or at least 30 minutes.
Yeah, at least minimum 30 minutes. Plumb arterial.
Like this.
Open bridge.
You have to open this 3 ways. There are 2 3 ways.
It should go through here, then come out through us.
Like that.
No, then it should be open.
Yeah.
It should be open.
This is open.
It should circulate.
So how long are we doing this now? How long did you say we're doing this now?
Every 10 minutes. Yeah.
So after 10 minutes, 10 minutes is over now. What you will do?
Wash with the
Every 10 seconds and do the same thing again.
So where's the blood going now?
the patients.
Oh no, just kidding you.
The idea you got it, why we are doing this? The clamping, unclamping?
Because clotting.
Clotting in the cannula. Because the stagnation of the blood in the cannulas will trigger clotting. So
you want it to go back on ECMO, the cannula should be fitted.
And you've got that and you tie, you can actually push them. Try as you might, you're not going to pack much on the floor. And actually one of the things I like to see on X-ray afterwards is just a little shift in the... No. Well, you don't need them because you've got the vessel's tied here and the vessel's tied there. So you if it's bleeding in the sort of VA neck cannulation in the kid, it's not from around here. It's usually just a bit of the skin edge, which is fine if you've got diathermy, but more and more when we're out and about and doing mobile ECMO, where most of our 8 French cannula in there, then the vessels are usually fairly small, and the chances of them staying patent isn't that high. And I think that would, 8 French I wouldn't bother.
Lead to higher B2. So what we are measuring actually, we are measuring delta. Delta B is the difference between B2 and B3, between B2 and B3. So it's B2 minus B3, which is higher, B2 or B3?
B2 has to be higher. B2 you need more pressure to pass the blood through the oxygenate to give you the delta pressure. Delta pressure is the difference between this and this. And since this one is positive and higher than this one, so delta B will be positive pressure. And when we look at delta B, we look at the baseline of delta B at the time of initiation. And this limit will allow for the expressions like that my P1 is going to draw blood gas or see low because nothing happening here. What else? You will see in the second. Both will be dilated in both sides.
The patient here. So our patient is intubated, okay, supposed to be hooked to a mechanical ventilator, has NGT, supposed to be hooked on a feeding pump, and you have your return ECMO cannula here, okay. Attached, of course, to yes, femoral, okay. So femoral drainage, and then you have your CV line, central line on your left area, of course, with the pressure transducer right here. And supposed to be, this is also connected to the infusion hose, all right? And then on the lower part of your patient is your Foley catheter. So that is all the contractions of your patient. It will be more challenging, of course, if you will have chest drains, okay? Because arterial line is also there on the left side, okay? Arterial line is on the left side also. All right, so basically when we are probing our patient, we have checklists that we follow just so that we will not forget important elements and we carefully follow all the instructions. So checklists are checked before the procedure, during the procedure, and then after the procedure. Okay, in the element of time, I don't want to go one by one with what is there in the checklist, but if you're going to look at the patient itself, okay, and considering that your patient will be prone for more than 16 hours, so then you would have to wash your patient. Okay, you need to take care of your patient, wash, and then do the eye care. Okay, tape the eyes if there's a need to tape the eyes. Immediately before proning, you can discontinue the feeding, right? Hold and then aspirate any residuals because you don't want to end up a patient prone and then vomiting. Okay, and then oral care should be done thoroughly, and then at the same time suction. You can also suction the ET tube. All right. So in your central line, you might want to check whether the central lines are properly sutured because not all intensivists would suture their central lines, right? Really? Yeah.
Just make sure.
Yeah. And then some of them are sutured, but some of the sutures are already
Because if the
modified.
line was not tight, the suture will come off, and just make sure that it's well sutured.
All right, and then you just have to make sure also that the length of your infusion bands are adequate enough so that when you're going to move your patient from right or left or wherever direction, it can the patient can readily go.
When you're going to do X-ray, then in between you're going to turn the patient and do the care and so it's okay. Prodding time only because patient is going to lie like more than 16 hours. Better to give bath and feel prepared. Yeah. Okay?
Okay.
So cover the patient again with all the standard linens what we will use.
So this time, doctor, is the other way around because the cannula is now here on the left side. So we're going to move the patient to the left, okay? Turn the side and then supply.
Move the patient to the left side. 1, 2, 3. Move. Right? Everything is good? Yeah. All right. On my count, put the patient on the side. 1, 2, 3.
Right side. Right?
Yeah. Now we should.
On my count, 1, 2, 3.
Easy because this is a mannequin.
Usually it take like 20 minutes or so. Take long time.
So sometimes even if you did not put your patient on proper sedation and paralytics, your patient will not cope with proning anymore. So you have to make sure that you...
If on full support, you can probably disconnect from the vent, correct?
Before and after we need to check our...
So it's really helpful, and the second option is that you can also, if you want to change a clotted circuit, you can use this one as a mini console, a battery with a console to run and to prime a new circuit. It's also used for hospitals. With a capacity of 4 hours each battery, so you have 2 batteries, you are at 8, so there is no hand crank. No, that's right. You don't have it, and it's helpful in an emergency. And I would like just, if you like, we have the ability to perform pulsatile movement. So if you look here, so now we are running on mini ECMO.
What's the last
We have to make sure either you have it fixed